Also have an advocacy training program. That's a program for fellows who are doctors going through a year of specialty training to become headache specialists, and for people living with migraine or caregivers as well. And that program teaches a lot about how to advocate for yourself, how to deal with the stigma of migraine, and just gets you more involved in our community. One of the things I said, we're in 24 cities around the country. The way that we decide which cities we host our events in is we go to cities that have headache fellowship programs. Those of you here who are living with migraine probably know there's a severe shortage of providers in the field of headache medicine. There are roughly 42 million people in the United States living with migraine, and only about 700 certified headache specialists. So if you do that math, it doesn't work out that favorably. And what that means is a lot of people, you have long wait times to see providers, and there are lots of areas of the country where there are no headache specialists. You're fortunate here in Boston that there are several, but I was just communicating with a woman from Las Vegas this week who doesn't have a headache specialist in her state and is looking at having to travel to get care. So Miles for Migraine exists to raise funds and support headache fellowship programs, to support the research that providers are doing, and to encourage more providers to get into the field. One of the reasons that we feel that there's probably a big shortage of providers in the field of headache medicine is that migraine and headache disease is a highly stigmatized disease. And it's not just the patients who deal with stigma. Providers are also stigmatized for their choice to get into the field of headache medicine. My headache specialist, when he was in school, his program director said, "You don't want to do headache medicine. Those patients are just, so difficult and you can't help them, and, do something like stroke or epilepsy." So that's pretty disheartening, right? We're all good people. We're not difficult people. We have a difficult disease. And with that stigma comes a lack of funding. Migraine is the least funded disease by the National Institutes of Health in relation to the burden that the disease imposes on society. And that's wrong. So Miles for Migraine is all about raising awareness, reducing the stigma, and supporting headache fellowship programs. We also feel it's really important to have in-person events like this. So I really appreciate those of you that are here today in Boston with me. I know it's not easy to get up. It's not easy to commit to coming to something when you don't know how you're going to feel. Some of you are dealing with migraine today. I ask you to take good care of yourselves. If you're not feeling well and you need to leave, that's completely okay. But I really appreciate your efforts to be here. Those of us who live with migraine know this tends to be a very isolating disease. We tend to spend a lot of time by ourselves in our rooms or in our homes. There are a lot of resources available online, but one of the things we miss out on is the opportunity to connect with other people like ourselves. So that's why we host in-person events, so that you can meet other people who have migraine. So I encourage you to take the opportunity today to meet some of the other people who are here, introduce yourselves. You're all relatively local to each other, and it's not uncommon for people to make friends and continue connections beyond our events. While you're here today, we're going to have a couple of breaks. We will also be bringing in some lunch. I encourage you to visit our sponsors from Pfizer and Lundbeck. They both have treatments available to help with migraine, and they're great resources to share more about those with you. Just to give you a quick run through of what our day looks like, we're going to have 4 presentations today. Dr. Ashina is going to start with a treatment update. Dr. Matthew is going to give a presentation on the relationship between headache and neck pain. Then we're going to take a break. Then Dr. Kulik is going to talk about moving from acute to chronic pain and how to manage that process. We'll have a Q&A panel after the 3 presentations. So that's why there's little slips of paper on your table. As you have questions, write them down. I'll grab them and I'll give them to the panel when we do that Q&A. And then we have a provider coming in this afternoon to do a mindfulness and meditation session. She'll talk about what that is, and then we'll do a mindfulness practice together so that you can actually experience mindfulness. So that is it for right now. Bathrooms, go out the door, take a left, and head straight down the hall if you need those. All right, so our first presenter today is Dr. Saeed Ashina. Dr. Ashina is an assistant professor of neurology and anesthesia at Harvard Medical School. He's a director of the Comprehensive Headache Center at BIDMC, Harvard Medical School. He graduated from the University of Copenhagen, Faculty of Health Sciences, Denmark. He's a member of the Education Committee of the International Headache Society. Dr. Ashina also served as a member of the International Headache Society Headache Classification Subcommittee for the latest edition of the International Classification of Headache Disorders. He's currently involved in several research projects at Harvard. His research interests include epidemiology of headache and chronic pain, quantitative sensory testing, human pain models, brain imaging, and structural brain lesions in migraine and migraine with vestibular dysfunction. He is an investigator of clinical trials in migraine, including clinical trials involving novel treatments in migraine and pain. Dr. Ashina.
Thank you so much for the kind introduction. And I'm really glad to be here and to talk about this disease. I'm a migraine sufferer myself, so this is very important for me as well. And thanks for organizing this event. I think this is important that we meet and talk about it. You'll have a lot of opportunities to ask questions after this presentation. So I will start to talk about the treatment of migraine. And these are my disclosures. The most important work I do is that I'm trustee on the board of International Headache Society, and we really try to bring awareness about migraine, not only in US, but also in the other parts of the world. Right now, we're working on a project in Kenya and in Philippines. So we're trying to see how we can bring the treatments or make it easier for patients in those countries to get treatments. Because we're lucky here, we have access to many options. And I'm also working, I do a lot of editorial work. I work for Cephalology, which is, I'm associate editor of this journal. But I also work for Frontiers of Neurology, BMC Neurology, and as well as Journal of Headache and Pain. So before we start talking about the migraine treatment, I would like to tell you about what migraine is, because it is important to know about this condition. And before you even start thinking about treatment, you need to know what migraine is. So looking here, you can see migraine can be divided in 2 groups, in episodic and chronic. And division is based on number of days. So if you have 15 or more days, you have chronic migraine. If you have 14 or less, you have chronic episodic migraine. And this is an artificial division, so we're still working on defining the chronic migraine. But currently, according to the so-called IHS or International Headache Society guidelines, this is a division we have now. Another symptom of migraine, so migraine is not just a headache. So a lot of times you will hear from others that, oh, you just have a headache, right? You just have a migraine. Just go and take some Advil or acetaminophen or Tylenol, right? But migraine is more than just a headache. It's a neurological disease. It has several phases. And for example, here you can see that migraine is also can be divided in with aura and without aura. So the aura is defined as a neurological symptom. It could be visual, it could be sensory symptom, it could be speech symptoms even occurring before the headache starts. And then, as you can see here, we already heard about a lot of burden associated with migraine. So you can see, I don't think so, but it's a very, very burdensome condition. And you can see 1.3 billion individuals worldwide are affected by this condition. And it's the third most prevalent illness in the world. And it's more common in individuals younger than 50 and during the most productive years of their life. And it is also a genetic, so it runs in the family. So you will hear, you may want to ask somebody in your family if they have experienced headaches, and you may be surprised they actually may have a migraine. And it is also very common complaint in neurologic clinics. So I'm a headache specialist. 100% of my patients are coming with a headache complaint. But if you go to neurologist, general neurologist, up to 60% of patients coming to neurologic clinic will complain of headache. And they'll have to deal with this problem. So we also have high levels of disability. And I mentioned to you about the chronic migraine. So roughly 3% of individuals during a given year can transform from episodic to chronic. And the chronic is unfortunately, one of the most disabling types of migraine, which could be sometimes difficult to treat and associated with more burden. But I would show you that recent studies show even people with 4 days of migraine per month can be as disabled as people who have 15 or more days. So we shouldn't focus so much on the numbers, but mostly on the disease itself. And sadly, and you heard about, because we don't have enough headache specialists in the country, we are really, and this is the United States, imagine other countries, right? So migraine remains underdiagnosed and undertreated, unfortunately. I have practiced in the 2 big cities in the US, in New York and in Boston. I see sometimes people coming in with migraines have not seen a doctor for 20 years, have suffered from migraines for 20 years without really a right treatment. And the good thing about it, if you treat the migraine, you're able to function, because I suffer from migraine. If I treat my migraine, I'm able to see my patients, I'm able to give my lectures, so I'm able to function. All right. So if you look at the general population, tension type headache remains still the most common primary headache disorder. And the reason we don't see many patients with tension headache in our clinics is because that's in my opinion. I still think this condition exists because there are some doctors who don't believe that this condition exists, but I hear from my patients telling me, doctor, I didn't have a migraine today. I had a different headache. It was not, I didn't have like light sensitivity or sound sensitivity. So it remains common. And what happens with tension type headache, most of the time patients will go to the CVS or Walgreens and buy the medication and take it without seeing a doctor. But when it becomes chronic, that can be an issue. But migraine remains as the second most common headache. And 10%, if you look at the prevalences of diseases in our population, 10% is a very common condition. So it's 1 or 2 out of 10 will have migraine in population. So if you go and ask people around, you will see that up to 1 to 2 people out of 10 will have migraine. So this is a lot. And followed by the cluster headache, which is less common, but a very burdensome condition. This is the chronic migraine. So if you survey 100 people, right, approximately 3 out of 100 will have chronic migraine. This is also a lot. This is equals to epilepsy, almost. Like epilepsy is around 1.5%, if I'm not mistaken, Dr. Matthew, right? The prevalence of epilepsy.
You're absolutely correct.
Yes. So this is basically to show you the distribution in the population. Now, how do you diagnose migraine? So to date, unfortunately, we don't have a specific test for diagnosing migraine. We don't have a specific MRI test. We don't have a specific blood test. But we're trying to find so-called biomarkers so we can diagnose patients based on those biomarkers, but we don't have them yet. So diagnosis is based on the clinical characteristics. Essentially, if the patient comes to your office and you ask those questions, the patient may fulfill criteria for migraine. So migraine is typically the headache which lasts anywhere from 4 to 72 hours. Now, can the patient have migraines lasting 2 hours or 5 days? Yes, but majority of patients will have headache lasting anywhere from 4 to 72 hours. And at least 2 of following characteristics: one-sided location, pulsating or throbbing quality when the patients may experience, and moderate to severe intensity. Usually migraine is very severe. Like we even do sometimes surveys in the population, and when we ask the question about, have you ever had a severe headache in your life? there's a very high probability that we can actually diagnose the patients with migraine just by asking that question. And aggravation by routine physical activities. It's really tough. You cannot really move. You cannot walk up the stairs, or you cannot do any physical activities during the migraine. This is in opposite to tension type headache, where in tension type headache, mild activities can actually improve the headache. And very characteristic of migraine is sensitivity to lights and sounds. We call them photophobia and phonophobia. They can be as disabling as pain. And sometimes patients cannot even function because of the symptoms. And nausea and vomiting. I suffer from migraine, and when I get nausea, I feel like it's sometimes worse than my pain. And I really, it's so uncomfortable. So let's talk about treatment. So if you look at this diagram, you can see treatment can be divided in non-pharmacological and pharmacological. It means that non-drug and drug treatment. And you can see here the patient education, and you'll hear more about it from the following sessions, that patient education is so important. It's important to know about the disease, have some expectation about the treatments, know what is out there and how you can treat. I always encourage my patients to read about migraine and to know about how to be in control of it. The more you know how to control it, the better it is for you, because it will be easier to function. And non-pharmacological therapies, again, you will hear about the role of psychology, mindfulness in the following sessions. As a matter of fact, there are studies showing that if you combine non-pharmacological therapies, for example, mindfulness or biofeedback with the pharmacological treatments, with drug treatments, the drug treatments become more effective. You have better efficacy of treatments. So let's talk about the acute treatment. So what is the goal of acute treatment? Why do we need that? So first of all, we need to, when we see the patients, we need to tailor the treatment to the both patient and attack. So we need to think about the patient and how the attacks are behaving themselves, right? So we have to talk about the triggers, because if you think about the triggers, right? A lot of us who have suffered from migraine, we know that there are sometimes triggers. Like I know, for example, if I have a very poor sleep, and if I worked a lot previous day, I would get almost 100% my migraine next day. And travel, sometimes changing the time zones can also do that. So it's very important to know. And for example, whenever I travel, when I'm going on a plane, I know that I'm going to get a migraine for sure because of my neck. You're going to hear the next presentations, and also because of the time zones, high altitude. I try to avoid alcohol, for example, because I know that I'm going to get the headache 100%. So I try to avoid alcohol on the plane, for example. And so it's important to have a plan. And how do we know about triggers? So the way we know about triggers is we keep the headache diary and we write it down, right? So we know that today I had a headache because of the rainy weather, for example. I know that's my trigger. But one trigger may not be enough. You may need to have several triggers, sometimes to trigger or to lead to the migraine attack. And we can't control the weather, obviously, unless we move to, I don't know, Palm Springs, California, where it's more stable climate. And now with the climatic changes, it's very hard, because now we see this, it's hard to know. Like, for example, a good example is a cluster headache, right? We know that cluster headache is usually common during the fall or springtime. But now, because of the climatic changes, we have patients coming in with cluster headache even in August or in July sometimes. And so it is important to know about triggers, how to mitigate them, how to control them. Treat early. This comes actually from our headache center. Dr. Bernstein, who did research, showed that if you take the medication early, it will be more beneficial. It will help you better than, and I can tell you from my perspective, because I do take rizatriptan, for example, for my own headaches. And if I take it late, it will be not effective. So I have to take ibuprofen or something in addition to it. So the earlier treatment is very important. And I know it's hard, and we'll talk more about it because there is a risk of rebounding, but it is important to know about it. And at times when there's a lot of nausea, or we call it also gastroparesis, some patients with migraine may experience that. Non-oral methods of drug delivery, for example, nasal sprays or injectables, could be an option. And of course, use the non-pharmacological treatments, quiet, rest, compresses, biofeedback, meditation. Sometimes even the breathing exercises can help to alleviate. The other day I had a migraine and I didn't take the medication. I wasn't sure if I should take it or not, but I just relaxed, did some breathing exercises and got better. And actually went to do the gym and did some mild exercise, and it helped me without even taking medication, ibuprofen or rizatriptan. So one thing that is very difficult for our patients is to decide when to take the medications. And this is challenging. It's even for me. And why? And there is a risk of medication, or we call rebound headache, overuse of medications. This is a paradox. I don't know why this is happening, but if you use headache avoidant medications on more than 10 or 15 days a month, your headaches can get worse. It's kind of counterintuitive to think like, why this is happening, but this is happening. We know that from the studies, from observational studies, from epidemiological studies, from our clinics. I remember I was once walking in London with my friend, and I was attending the headache conference. They had Jewish immigrants. They were Jewish immigrants from Soviet Union and US without insurance. I still didn't understand why they didn't have insurance. And he told me, like, say it's funny, you're here attending the conference in London, and we're walking now like in the streets here, enjoying the city. But my mom suffers from headaches. She takes Tylenol every day. And I told him, I asked him some questions to make sure I rule out the red flags. And we found out that she takes Tylenol every day for headaches, and that she's doing that for years. And I told him, Edward, what you need to do is tell your mom, call her, tell your mom to stop Tylenol. She's going to have a horrible headache for two weeks, because we know that this happens when you do this so-called cold turkeys. But she's going to feel better afterwards. Roughly 6 months later, I got an email from him. I have it in my Yahoo mail box, saying that, remember, it's funny. Remember we talked about my mom, about her headaches. I told her to stop the medication. She had a horrible headaches for 2-3 weeks, and now she doesn't have any headache. So this is an observation, but we know that there's a data about it in both observational and epidemiological studies. And one of patients, and he's actually a scientist now, who he made a petition to FDA and asked them to add to the label about the risk of medication overuse. And it happened. Finally, FDA now states that medication overuse headaches warning is you can see there on the label. That's for the migraine formula, for example, the drug. And so it states that headaches may worsen if the product is used for 10 or more days per month. So this is to educate the public about these risks, and now we have that. And we always emphasize it during our consultations. We ask the patients, it's very hard because you want to take the medications because you're suffering, but you can do more than that, right? You can take preventative drugs, for example, right? If you want to decrease the use of acute medications. Unfortunately, medications listed here, opioids, which are still being prescribed to some patients, can be very high risk for rebounding. For example, opioids and betabital containing, like it's there's a brand name for it, like Fioricet. I don't know if you probably heard about it. We don't know why, but there's a high risk of rebounding with this specific drugs. But as you can see here, all painkillers can potentially, like we're talking about NSAIDs like ibuprofen, naproxen, triptans like rizatriptan, sumatriptan, or Imitrex, we call it, can cause rebound headaches. The only difference now, because we have these newer medications, which we so-called CGRP targeting acute medications, which I'm going to mention later, they are not posing the risk of medication overuse. So this is some advancement in our science, and it's becoming easier now for us to treat our patients because of this particular medications don't have a risk of medication overuse. So this is an example of one of the patients coming into my clinic. So Jane, she has migraine attacks. She has them 10 times a month, some less up to 2 days, which is can happen. They can be moderate, but they could be, sometimes there could be things, she can do sometimes things, but it's too much for her because the headaches get worse. She has to be in a dark room, and some of the headaches are with vomiting. Migraine attacks can be associated with sometimes with prolonged vomiting. She takes Excedrin and sumatriptan. So the main concern here would be she has 10 days a month with the headaches, right? And she takes Excedrin and sumatriptan. And imagine that if this goes beyond the 10 days, right? What happens? Then she has a risk for rebounding headaches. And so what should we do in this situation? So we should think about prevention, of course, but we'll talk about later. But this is the overview of the acute medications we have currently available for treatment of migraine. So we have triptans and ergots, which are migraine-specific drugs. I'll show you later. The most common is sumatriptan, followed by rizatriptan and all others. We also have this medication called lasmiditan. It's rarely prescribed because of it can be associated with dizziness, and you cannot drive for 8 hours after taking this medication. But it's an option for people who have not responded to triptans, for example, and need some rescue or backup drug. That could be something that you can take in the evening if you're at home and not planning to drive. Interesting thing about this medication is because triptans are working on serotonin receptors, right? They work on serotonin receptors on both vessels and the nerves. This one is more specific for nerves, so it doesn't affect vessels, which is sometimes a concern if there is an issue with heart disease or problems with hypertension and so on, right? High blood pressure. Then we have the non-steroidals, which has been used for many years for migraine. I mean, we have ibuprofen, we have just shorter acting and a longer acting. We have naproxen. Diclofenac has a great evidence for work and has been used for patients with migraine for many years. Then we have so-called anti-nausea medication or dopamine-based medications like chlorperazine. It also goes as a compazine. Metoclopramide also goes as a Reglan. A lot of times, the patients would go to emergency room, urgent care center. They will give IV. They will get IV metoclopramide or Reglan, for example. So aside from being the anti-nausea medications helping with the nausea, they actually help with the pain too. They work on the pain receptors. And then we have the addition of the newer drugs called gepants. We have ubrogepant and rimegepant, which is the ones I was mentioning about the lower risk of rebounding, for example, with this treatment. And you will see the interesting part about rimegepant. It has a dual indication, so it can be used both as an acute as a preventative drug. So when I show you the drugs, you saw those the table. Now we divide them also in non-specific and specific. Specific means that they are indicated for migraine. They are based on migraine mechanisms. So we're targeting the migraine mechanisms with these drugs. And these are the ergotamines, which are the old ones. They were introduced in the 60s, actually. And DHE, which came later. And then we have triptans, we have gepants, which are the rimegepant and ubrogepant, which I'll show you on the table, and the DTAM, which is lasmiditan. But the other ones you can see here, they are non-specific. For example, NSAIDs, combination analgesics, which could be like Excedrin, for example, is the one which is an example of combination analgesics. And then we have those anti-emetics, which is anti-nausea medications. Steroids, sometimes used to break the headache cycles, and then opioids, which we don't recommend, but they have been used in some patients. Now, what you can see here is that if you look at the data, you can see that there are actually good data for non-specific drugs for management of migraine. But we like more migraine specific because we want to target the migraine mechanisms. So in certain countries where they have so-called step therapy, they have to go first through the non-specific drugs, and then they're able to get specific drugs prescribed. We're lucky that we can sometimes bypass that, and we can prescribe our patients according to their disability, and we can actually prescribe triptans as a first choice now for most patients, and it's getting easier with the prescription with the gepants now as well. So if you look at individual attack, so first you have initial therapy, and it's, again, as I showed you, it has to be based on the attack profile, the symptoms. For example, if the patient has nausea, you may want to target the nausea together with the pain. And then you also look at the level of disability. The more severe and the more disabling, most likely the sumatriptan or triptans are the first choice here. And then you also need to have a backup. So if the triptan is not working, for example, or one drug is not working, you need to have a backup. So every person with a migraine should have this plan, in my opinion. So have an initial therapy, a backup, and rescue therapy. The rescue therapy will be when the backup is not working, for example, and typically these are, for example, metoclopramide, those chlorperazine, those anti-nausea medications, which could be used if the initial therapies are not failing. And at times it can take months for an individual to find this plan, or this recipe, like when the headache is there, how I'm going to treat it. But it is important to have it. So you should be in control of your headache. You should know how you want to target it. before you call your physician, because sometimes you may not get the physician on the line right away, and instead of going to the emergency room, which will be very problematic, right? I mean, emergency room is not the best place for a person with migraine. Too much noise, too many people, too many stimuli there. So if you look here, we also have transitional therapies. So what are transitional therapies? One of the good examples of transitional therapy is menstrual-related migraine. So menstrual-related migraines are typically occurring 2 days before the menstrual period, or sometimes during, and last for a couple of days. So for those, for example, periods, we have transitional therapies. We can use anti-nauseants. We can also use steroid taper. We can use sometimes muscle relaxant. For triptans, like longer-acting triptans, for example, naratriptan and frovatriptan can be given once or twice a day for 3 to 4 days. And in that way, we can actually break the headache cycle during this. And you can see here on the right, this is a headache calendar. And this comes from the studies. So we know that during certain years or even months, the headache frequency can fluctuate. So there will be certain weeks where the headaches are more frequent than others. And at times it could be so severe that the patient cannot function, right? In that situation, we can consider transitional therapy. Another thing which I think Dr. Matthew is going to talk more about is the nerve blocks. So we do utilize nerve blocks as a non-drug treatment. We still use lidocaine. In this particular study, they used 1% of lidocaine and injected supraorbital nerve and great occipital nerve. And you can see here that after 30, 60, and 120 minutes, there was improvement in the pain. And the red line shows the combination, and the combination of targeting both nerve was helping the patients. This is something we can use in our clinics or even in emergency rooms if the patient comes in with severe headache to break the headache cycle, also as a transitional therapy. But you'll probably hear more about the neck and the headache. You do use those treatments also as a preventative treatments as well for our patients. Now, should Jane get a preventative? What do you think? She should get a preventative? 5 minutes, okay. So I think she should get a preventative because, as I told you, she's at risk for rebound headache, right? There's so many headaches. So you can see here, this is the list of CGRP targeting drugs, which are the newer drugs, which we have. We have erinumab, galcanezumab, fremanezumab are self-injectors. They're given once a month. And eftinizumab is an infusion drug. It's every 3 months. And there's some data showing that people who have not responded to previous drugs, for example, conventional treatment, and have not responded to self-injectors may respond to eftinizumab, for example, the infusion drug. And remidipan, remember I showed you that it was also used for acute therapy, but can also be used for prevention, actually, taken every other day. And atogepant is taken every day, and it's also a CGRP antagonist used for prevention. And then we have anti-seizure, antidepressant medications, anti-blood pressure medications. And I tell the patients, we're not targeting your blood pressure, or we're not targeting your depression, or we're not targeting your, you don't have a seizures. We're using it for prevention of migraine. These medications work on pain pathways and targeting the pain pathways. But we heard about the stigma. It could be sometimes associated with a stigma because patients may feel like we do prescribe it for depression. We don't, actually. And then we have onabotulinum toxin, which is another non-drug therapy. Well, it is kind of a drug therapy, but it's not the pill, and an oral therapy, and used for chronic migraine only. And here we have so-called alternative treatments, and we have petadolics. So it is important to know when you purchase the product petadolics or butterbur, it has to be PA-free. It's an alkaloid, which is defense mechanism of the plant, actually. And it can be toxic for the liver. So it's very important when you buy this, read and make sure talk to your doctor about this product before you take it. And then we have riboflavin, we have magnesium, we have feverfew, CoQ10, melatonin, and of course, medical marijuana is also something that is emerging now. There's a lot of studies going on it, and I think it looks promising. But we need more studies, and unfortunately, there are some federal regulations which are still making it difficult to prescribe it on certain hospitals. But there are clinics run by physicians who can offer you those treatments. So if you want to go that route, it's very important to have a physician who is certified to prescribe it and knows how to and what to prescribe. And these are the devices you can see here. Some of them are actually available without prescription. For example, so-called cephalate device there, which targets the trigeminal nerve. There's this one called Relievio. There is a vagal nerve stimulator. There's Neurivio, which is a device which is called conditioned pain stimulation. And then there's a green light. So green light is also shown to be relieving the pain and symptoms of photophobia, as well as even have some effect on anxiety. So now, other than treatments, it's important to emphasize the healthy lifestyle, right? To make sure the hydration, right? So it's important. There's my water here. So and know about develop the body awareness. Know about how you live with migraine. Practice meditation, relaxation. Engage with people. We have Miles for Migraine, right? We have a lot of groups, patient groups. It's very important to call up, attend the meetings. Speak to others who have suffered from migraine. Make sure you relate, you understand the conditions. It will help. It will help also to promote, we can go then to politicians and tell them about that we need more funding for research, right? So we can help our people better. Stigma, you already heard about it. So stigma is very well known in many neurological conditions. For example, epilepsy, depression is a psychiatric condition, which is also associated with a lot of stigma. But migraine is also associated with stigma. And we actually have more data now showing that, like we have a recent study, which I was honored to be involved in. We showed up to 32% of patients with migraine have stigma. It can be, stigma could be interpersonal, so it could be sort of external, so other people, what they think about you, so negative beliefs and negative attitudes towards you, but it could also be internal, self-stigma. Patients sometimes feel guilty and that they have a migraine and they are basically like they're the cause of it, and that's why they cannot function. And the others are suffering from them. And this is a structural stigma, which is basically at the governmental level or at the societal level about like, oh, you just have a headache, right? This is a migraine, this is nothing. But this is not true, right? And this is the form of population stigma, which is out there about the headache conditions. And one thing is to fight against stigma is advocacy. And that's why the Miles Migraine, in my opinion, is a really great organization that can fight against that. I'm using the CHAMP language now. It's actually all available online. I'm scared to use now because every time I publish the papers, I make sure that I'm not using, for example, a lot of times when you read the papers, it says headaches or migraines. Why do we not say asthmas or, for example, other conditions? So it's best not to use the plural, but use singular because then you emphasize more on the disease. And if you ask ChatGPT, for example, about the migraine or a headache, it will actually give the plural too. Actually, we should change it now, I hope. So so make sure you talk about your disease. You seek advice, get support from others, insist on accommodations, work with your employers. It's gotten easier, better now with employers. They understand about accommodations needed. But I always have my patients to reach out to the employers and create certain accommodations, make sure the lights and everything, the screen protectors and everything are there for them. So the pluses, which you're going to hear about the neck pain today, but also another thing. So patients with migraine may suffer from depression, anxiety. They may suffer from other pain, rheumatoid arthritis, increased BMI, poor sleep. These are not directly related to migraine because they're different physiologies, they're different mechanisms, but they may make you prone or make you easier for you to get a migraine. So it's very important to address those issues in addition to migraine. But I know it sounds a little crazy, but it's actually an amazing time to have migraine. Why? Because we have these new drugs, which I told you about, right? So when I started practicing like in like 90s, I mean, we had nothing, not even the onabotulinum toxin. Now we have so many treatments for our patients. And now this is another thing. Like now we also reinvent. So DHE, which is a known product, but now there's a nasal formulation, which is more effective, which is available there. And also we have new drugs coming out soon. So we have recent study by Ashina Masood, who's my brother. Actually, he studied PACAP, which is a new target. It's basically another peptide which we can target and hopefully can stop the migraine. We also have kappa opioid receptors. We have orexin receptors. So a lot of things going to come. So we are lucky that we have this potential new targets, and we can offer that in the future to our patients. So probably it will take maybe 5 to 6 years, but we may have something. If everything goes well with the studies, we may have an anti-PACAP medication soon. So in summary, it's okay to have a migraine. You can have a migraine. It's not okay to not treat it and not being, suffer from it. And think about the triggers. Make sure you work with patient organizations, do advocacy for yourself and for the others, and also make sure you get the right treatment, avoid the rebounds. Ask your doctor about prevention. A lot of times patients don't ask about the prevention. Ask about the prevention. It's very important to emphasize on prevention, because acute drugs are not answer to the headaches, because they can be associated with rebound, but also they are good to have them for that specific day when you have a migraine. But in order to decrease the headache frequency, you need to be on preventative treatment. I know I don't have so much time. Thank you for your attention. And this is our clinic, and you can follow us on X. I mean, no, I know it's not the best. We're moving away from X now, and we're looking for others. But so far, it's the only platform we have. We also have we're trying to reach out to our patients. We do have clinical studies ongoing. So if you're interested in being part of our research studies, please reach out to us. We do have right now a study looking at the green light and how it can affect the brain. And another thing is that we'll have time for questions later, right? After presentations. Thank you so much for your attention.
Thank you so much, Dr. Ashina. That was wonderful. I feel like we could have you present for another hour probably and go into more detail on a lot of that. It's hard to cover everything in a short amount of time. If questions came up for you during that presentation, make sure you write them down on the cards, and we'll go through those when we do the Q&A in a little bit. All right, next up is Dr. Paul Matthew. Dr. Matthew is board certified in neurology and headache medicine. He's an assistant professor of neurology at Harvard Medical School and an affiliate member of the Harvard Medical School Division of Sleep Medicine. He has clinical appointments at Mass General Brigham Health and Atrius Health, as well as a teaching appointment at the Cambridge Health Alliance. In terms of his academic responsibilities, he has been involved in the education of countless neurology, psychiatry, internal medicine, family medicine, dental medicine, pain medicine, and headache medicine trainees. He's written over 90 publications and has presented at both national and international conferences. Dr. Matthew is a graduate of the American Academy of Neurology's Palatucci Advocacy Leadership Forum. He's participated in multiple advocacy efforts in Washington, D.C., led by the American Academy of Neurology and the Alliance for Headache Disorders Advocacy to improve patient access to healthcare and research funding. You might also find him on Comedy Central. Just kidding. He's a comedian. He tells a lot of dad jokes. So just fair warning, they might be coming during this presentation on migraine and neck pain.
Thank you for that unnecessarily lengthy introduction. It's always a pleasure speaking after Dr. Ashina, because he always finds a way to butt into my time. He took 10 minutes, but that's fine because he gave a fantastic presentation. A couple things I will say about some of the things he mentioned is, number one, there's a bit of a misnomer, and I'm a stickler about this, that genetically people either have tension type headache or migraine. And I say that because a lot of patients will say, oh, this is a low-grade headache. This is just a tension type headache. Let me not treat this. And then they wait for it to escalate, get bad, and then it's not quite at the point of no return, but it gets to a point where it's not going to respond as well to treatment. And so treating migraines, I often use the analogy of it's like a lit match. It's very easy to put out a lit match. Once the whole building is on fire, it's a lot harder to stop. And I actually show this to my patients on their headache diaries. It'll be a 7 on day 1, and then it'll be followed by an 8, 9, 10. And I tell them on day 1, when it was a 7, if you had treated earlier, that might have been a 3 or 4, went away, and you may not have had those trailer days. The other thing I will say is Dr. Ashina did talk about a lot of different treatments. And you might be wondering, it's kind of weird. Blood pressure medications, seizure medications. These are all very, very different medications that are all treating a single disease process. But the fact of the matter is migraine is kind of a big umbrella term that many of us believe encompasses a lot of different subtypes. So there are people who have the genetics where their migraine will respond wonderfully to beta blockers, others calcium channel blockers, others anticonvulsants. So he did talk about research and hope for the future, but the hope is that at some point we take a history, we examine the patient, hey, you have migraine, we give you a blood test, and that tells us what subtype you have, and we can go right there instead of this, okay, let's try this, okay, that didn't work, let's try this, that didn't work. In our defense, what we often try to do is a lot of these medications do have side effects that can be beneficial. For example, if you have constipation, if you have muscle cramps, we'll often suggest magnesium because that's a supplement that can treat both of those other issues. For example, if you have seizures, we'll probably pick an anticonvulsant which can treat both seizures as well as migraine. So, moving on to my talk. It's not advancing. I know you guys want me to pump my brakes, but I mean, all right. So some disclosures, geographic disclosure. I'm from the great state of New Jersey. As some of my patients in the audience know, that does come with some sports disclosures, which usually get some boos. Yes, I did hear one. Thank you for that. More often pity than anything else. But, you know, as I tell patients, that one of my patients said, hey, listen, you've lived in the New England area for 15 years now. When are you switching? And I said, listen, you can't choose your family. So it is what it is. Oh, and I thought Katie would have said this. If any of you have any cell phones, please silence them, unless you have a very amusing ringer and you like to be embarrassed, because I will heckle you if it goes off during this talk. All right, weather disclosure, it is cold, gloomy, and rainy, but it is nice when Mother Nature smiles at you. So if you look very closely at these geese as they're swimming in formation, they're actually spelling my name. So it's always nice when Mother Nature gives you the nod before a talk. All right, quack, quack, who's ready for some snow? Yeah. All right, and then finally some nomenclature. I'm Dr. Matthew. If my wife was here, it would be Dr. Matthews, plural. She's the smart one. She's a dentist. This is the one piece we wrote together, and then she swore never to publish with me or work with me clinically ever again. All right, and then last but not least, it is Movember, which stands for Mustache November. That's when men wear mustaches for prostate and testicular cancer awareness. As like in October, people wear pink to remind people about breast cancer awareness. You do a self-exam, you do your mammograms. If you catch something early, very treatable. Likewise, with testicular cancer, very aggressive, killing teenagers and 20-year-olds. Colleague of mine, young guy in his 30s, father of two, felt a mass, ended up being testicular cancer. Luckily caught it early, unilateral orchiectomy, cured. But as you can imagine, if you let that go, spreads to the other side, a lifetime of sterility and hormone replacement, not good. On the other end of the spectrum, prostate cancer, more common, much less aggressive, and more so in elderly men, but kind of the same story, catch early, and that's it. In case you're wondering, when I left the Cambridge Health Alliance because we moved to the South Shore, one of the nurses said, you know, Dr. Matthew, your mustache reminds us of Tom Selleck's mustache, but he was Magnum PI, which would make you Magnum PM, my initials, and then they photoshopped my head onto an actual Tom Selleck Magnum PI promotion. All right, so let's get to the meat of the conversation here. We are going to talk about neck pain and headache. As Dr. Ashina so eloquently put it, migraine oftentimes will be influenced by triggers. And a lot of the time, patients will get hung up on, I had a slice of pizza and then I had a headache. I'm never eating pizza again, when in fact, they were up all night. They've been under a lot of stress. There's a storm front coming in. So a lot of the time you need to take into consideration all these different triggers and how they can influence migraine. And I often tell my patients, trigger anticipation is really an important strategy. So I didn't sleep well last night. I'm under a lot of stress. There's a storm front coming in. Let me have my acute med on me. So the second I feel something, boom, I can take care of it. And like I said, in some situations, you may prevent a multi-day cycle from happening because you take it early enough. So this is a little bit of a busy slide, but neck pain and headache, I kind of put into three buckets. There's people who have migraine with cervicogenic features. There's people who have tension type headache with cervicogenic features, and we'll dissect each one of these, occipital neuralgia and migraine cervicalgia. So this is kind of a roadmap of what we're going to be talking about today. So we'll start with migraine and cervicogenic features. So in the diagnostic criteria for headaches, there's something called cervicogenic headache, which basically means that you have some kind of neck pathology that's causing your headaches. So clinical and or imaging evidence of a neck disorder known to cause headache. Headache developed around the time that the disorder started. Headache has significant improvement or resolves with treatment of the neck issue. Neck is stiff and headache is worse when attempting neck movement. So in my experience, the vast majority of people who have cervicogenic headache before this neck pathology even kicked in had tension type headache or had migraine and now has this neck issue exacerbating that headache. So on neck imaging is very common in patients with headaches. So a lot of the time in medicine, not just in headaches, but in medicine, you will find somebody who has horrible symptoms and just a minor pinch on one of the nerves coming out of the neck. On the other hand, you will have someone who has an MRI of the spine and it looks awful and they have no complaints at all. So you cannot always correlate imaging findings with the symptoms that the person is having or actually the extent of the disease. Dr. Ashina and I over the years have seen many, many patients, and it's amazing. You have patients who have a spinal cord that's almost completely compressed and they're walkie-talkie, no problems, no weakness, no sensory problems or anything like that. And we immediately send them for neurosurgical decompression because that's a medical emergency, because if it does strangle anymore, they'll be quadriplegic. So that should really emphasize that, the imaging does not always correlate to the disease or the symptoms that they're having. So as I've mentioned, tumors, fractures, all these things can contribute. And again, neck pathology developing later in life can spur on what's called kind of this wastebasket cervicogenic headache. So according to the diagnostic criteria, features that support cervicogenic over migraine, side locked. Again, that really does not make sense. Migraine is one-sided a lot of the time. Most of the time it's a dominant side, but if you ask somebody, I could ask any one of you, when you have a really bad migraine, you'll have a dominant side, but the other side of the head will ache to some extent. It won't be as bad, but it'll ache to some extent. Posterior to anterior radiation, again, that can happen with migraine as well. And again, this is according to the diagnostic criteria. Migrainous features can be present, which supports basically the person had a predisposing migraine or tension type phenotype, and then later on developed this neck pathology that's now kind of driving the bus. So I'll move on to occipital neuralgia, which is kind of my biggest area of clinical interest. So how many of you are familiar with sciatica? All right. So sciatica, as you know, is when you have a pinched nerve in your lower back, and your lower back, the nerves come out down into the leg. So someone with sciatica will oftentimes complain of chronic back pain, and then when it gets bad, they have that pain going down into the leg. In the upper neck, you similarly will have nerves that run up the back of the head, and that can manifest similarly, where you'll have these jolts or stabs of pain lasting seconds at a time. And when that goes on for long enough, you'll get a steady achy pain. And in the lower part of the neck, those nerves actually go into the arms. So you'll have people who, when they have neck pain, when it flares, they'll have this shooting, stabbing pain in the arm, or even after some time, a steady achy pain in the arm. So occipital neuralgia, like I said, pain is isolated to the back of the head. It could be either side or both sides. It's a stabbing, shooting, lancinating quality. It can progress to a steady achy pain, as I had mentioned. The area is usually tender to touch. So the scientific term for that is cutaneous allodynia, where a normal contact is now very irritating, which is actually very common in migraine as well when people have a really bad attack. That's why some patients, they like to be as still as possible, but even laying down on a pillow can hurt. And patients will often say, my hair hurts when the headache gets really bad, which is another form of cutaneous allodynia. And response to neuroblocks, which we're going to talk about in an upcoming slide. So this is an image which kind of demonstrates those nerves that I was talking about. So there's the third occipital nerve in the midline, the greater occipital nerve, which runs up to about the apex, and then the lesser occipital nerve, which wraps up and around the ear. And again, this is down in the cervical spine. So with these nerves, they basically exit the spine. They go through muscle, tissue, and fascia, twist, and then go up the back of the head. So as you can imagine, it's already a pretty tortuous course in someone who doesn't have any issues. But then imagine someone who, for years or even decades, works a desk job and they kind of get this posture and it just gets worse and worse and that area gets tight. Someone who's involved in a motor vehicle accident, someone who's involved in a sports injury, any one of these three can commonly lead to occipital neuralgia to develop. So this really became a big interest of mine, and serendipity has an interesting way of happening. So this young lady came to me who's applying to medical school, said to me, you know, I'd love to do a research project with you. So we looked at 800 patients who came in complaining of just headache. And this isn't Mass General Brigham, this isn't BI, this is the Cambridge Health Line. So this was a community hospital-based headache clinic. So out of 800 patients, as you can see, 195 of them not only had migraine or post-traumatic headache, but also had occipital neuralgia, which really raises the point that one person can have multiple diagnoses at the same time. So it's kind of like someone who has arm pain. They can have carpal tunnel in the wrist. They could just usually have a pinched nerve. They could also have shoulder pain. They could have multiple problems that give kind of similar overlapping features. And in this case, it was occipital neuralgia and their other primary headache disorder. So chronic migraine, no surprise, was the most common comorbidity with these patients. And the odds were higher in people who had an elevated BMI, a higher age at presentation, and more likely to happen in chronic versus episodic migraine. And undiagnosed or inadequately treated occipital neuralgia, to no surprise, led to an increase in the frequency and intensity of migraine. So the way I describe primary headache disorders is, imagine a car alarm when all the alarm goes off, but the radio goes off, the air conditioning goes off, and the car goes in reverse. That's kind of like what migraine is, where now you have a headache, but light bothers you, sound bothers you, nausea, vomiting, all these inappropriate things. Now imagine if a child comes and starts kicking the tires on that already sensitive car alarm. That's exactly what happens when you introduce occipital neuralgia. That's what happens when you introduce low back pain. Any of these triggers was now kind of setting this alarm off more frequently and more intensely. And so neurologists love nerdy puns. The title of the paper was "The Diagnosis in the Back of Your Head, the Prevalence of Occipital Neuralgia in a Community Hospital-Based Clinic." So neuroblocks, as Dr. Sheena had mentioned, are relatively safe, easy to do procedures in the office. They can be performed for the acute treatment of migraine. If somebody's in what's called status migrainosus, it's been 2 or 3 days and that same cycle is not breaking. Certainly it can be useful for that. There can be some prolonged benefits even after the anesthetic has worn off. Many of you who've been to the dentist, you've gotten some lidocaine, lasts like an hour or two. One of the longer acting anesthetics, we often use Marcaine or bupivacaine. That usually lasts a day and change. So that's my preferred agent. If you're going to do an injection for hopefully long-term pain relief, why not use a longer acting agent? So one of my colleagues, Bill Young, down at Jefferson, actually did a study where they checked pain and sensation scores before and after performing nerve blocks in the back of the head, and they found that the sensitivity scores actually improved after the nerve blocks, which tells us that not only did it work on the nerves back there, it actually worked centrally on the deeper parts of the brain, which help modulate pain more globally. So nerve blocks, like I said, are performed with anesthetic. You could also use steroids. We generally only use steroid for cluster headache among all the different headache diagnoses. And the reason for that is there's really no evidence that adding steroid adds any benefit to any of the other headache disorders. Steroids do, of course, have some risk to using them. When you use steroid, it limits how often you can do the injections. So that's why people who get steroid injections in their low back, basically the interventionalist will say, sorry, you're pretty limited to just 3 or 4 times per year. The other issue with steroids is it can cause atrophy of the skin, meaning wasting. I remember seeing a patient years ago who had 4 dime-sized divots in her forehead. And I asked what happened. And they said, oh, I had some nerve blocks in my forehead. And unfortunately, the pain clinic had used steroids. So I called and I said, hey, listen, I have this patient of yours who has, the skin atrophy issue. And he cavalierly said, oh, that happens sometimes. So fortunately, over time, it did come back and she made a full recovery. But really, there's no role for steroids unless it's cluster headache. So moving on. So when you think of occipital neuralgia, do you have a stabbing pain that can occur in that nerve distribution in addition to the migraine? Does this stabbing pain happen even if you don't have a migraine? And that should really tell you, this is a separate diagnosis from migraine. And again, you can use these nerve blocks for termination of a bad migraine cycle, cluster with steroids, and even a routine visit. If a patient of mine happens to have a headache that day and we have some time, I'm happy to do a nerve block just to break the cycle they're having. So speaking of nerve blocks and occipital neuralgia in particular, I found that the technique that I learned at Mayo Clinic, many of my patients, I would see them back weeks, months, or even years later, and they said, oh, I still have migraine, but that shooting, stabbing pain, I haven't had that since you did that injection. So the same group that I did the prevalence study on, we actually looked at these patients. We looked at 41 consecutive patients. And interestingly, the duration of benefit on average was in the range of 200 plus days. And it really is amazing that patients would have such a long duration of benefit. And the range was 400 to 840 days. So some of these patients years later would come back and say, I still haven't had the stabbing pain. So the thought is that if this is your skull and this is your scalp, we're actually going into that space with the needle and causing a tenting of the skin. And some of that pressure can actually release the tension on the nerves. So doing larger volumes, we usually typically will do 6 cc's per side, which is a big volume. We found that that can be quite effective. And the title of the paper that we wrote was One and Done, because fortunately that's how it is for some of these patients. So patients who have chronic migraine as well as occipital neuralgia run into two big problems. Number one, making the diagnosis, because a lot of the time clinicians will hear, oh, you have light and sound sensitivity. It's all just migraine, without taking that deeper dive and realizing there's another problem. And then the second issue is that once you get the diagnosis, a lot of the time people will do low volume nerve blocks, which may not have the same effectiveness. And then what goes in the chart? Patient did not respond to nerve blocks. And then nobody will attempt them again, thinking, okay, it didn't work. Let's not even bother going down that road, which is really, really unfortunate for patients. So this is the poster that we presented at both the American Headache Society and the American Academy of Neurology meeting. And so this is how I perform occipital nerve blocks. I do an injection down here, which is 6 cc's. And as you can see, it covers both the greater occipital nerve and the lesser occipital nerve. And again, this is something that I do in the office. This image is from what I call the Harvard Pain Manual. It's Principles and Practice of Pain Medicine. But easy enough to do. Usually patients, I'll have them hang out in the office for a half hour. And when they feel comfortable, I encourage them to have someone drive them. But if they're feeling okay after that wait time, they're able to drive. So I put this image up because, as you can see here, this is kind of a complicated drawing. My colleague, Dr. Robertson from Mayo Clinic, put this image together to accompany one of her articles. So the ear is a very interesting part of the body because there's so many different nerves that innervate it. And as you can see here, there are contributions from the lesser occipital nerve as it comes up and kind of wraps into this area. So interestingly, I've had patients where I do an occipital nerve block and they're like, oh, that tingling itch that I was having or that pain deep in my ear that I was having is actually much, much better or gone after an occipital nerve block. The ear also can confound because if people have problems with their temporomandibular joint or TMD, temporomandibular dysfunction, they will often complain of ear pain as well, because again, that joint is just anterior to the ear. And so how do you treat refractory occipital neuralgia when they've tried all these different medications? They've tried nerve blocks, they've tried interventional injections, they've tried radiofrequency ablation. Well, you know, unfortunately, when all of these things fail, there is surgical decompression. Now, just to give you a sense, I've had thousands of patients with occipital neuralgia, and I've referred 25 to date for occipital nerve decompression surgery. So this is definitely not a go-to thing. This is not something you should, have as a first option, but it is something to think about if you have really refractory occipital neuralgia. I do caution some people, some surgeons do these surgeries labeling it as migraine surgery. I would absolutely be seen by a headache specialist if you're even thinking about something as extreme as surgery. And certainly if you have just garden variety migraine without any of this lancinating, shooting, stabbing pain, I would exercise extreme caution before thinking about undergoing any surgical procedures. My mentor at Mayo Clinic once said, Fred Cottrell, if you cut through a pain-sensitive structure, chances are pretty good you might make the pain worse. So, and once you cut something, there's no way to uncut it. So the last topic we're going to talk about is migraine cervicalgia. So as you know, Non-noxious stimulation can a lot of the time, or shall I say non-noxious sensory input can be uncomfortable in somebody who has migraine. So for example, these lights blinding, my voice painful, hopefully not today, but my voice painful, nausea, osmophobia, certain smells really irritate me when I have a migraine. A little less known in terms of the word kinesiophobia. When I have a migraine, I need to lay still because any kind of movement will irritate my headache. Dizziness and vertigo, cutaneous allodynia, which I had mentioned earlier, as well as afferent from joints and muscles. So the thing all of these things have in common is the structures sending the signal are working appropriately, but the brain receiving the signal is amplifying everything. So even in the case of vertigo, I'm not sure if any of you have had vertigo, but basically there's in your inner ear, there's a fluid. And when you turn your head, that fluid moves and tells you that your head moved. When you have migrainous vertigo, that signal is correct, but the brain is now amplifying it. So you turn your head and you have this sensation like you are still moving, even though you're not. And so this brings us to afferents from joints and muscles. So before I get there, cutaneous allodynia is contact sensitivity, as I had mentioned, the hair hurting and all these different types of things. So when I was a fellow at Mayo Clinic, we actually did a study looking at this and how all these different things can be irritating or exacerbating a migraine. And we found that in patients with chronic migraine, about 90% have some degree of cutaneous allodynia when the headache is very severe. And as I mentioned, neurologists like nerdy, punny titles, so the title was A Touchy Subject. All right. So this is a diagram that I made. As you can see, there's sensory hyperexcitability, which is the dashed line here. So that is light bothering you, sound bothering you, nausea, all these different things. And unfortunately, as you can see, this peaks with the headache pain peaking as well. And then as both of those things ramp down, then you get to this post-ROM phase. The other thing you'll see here is aura, which we didn't talk about too much. Aura is when your brain is doing things that it shouldn't be doing, or certain regions of the brain are hyperactive. This is a bit of a misnomer. Aura can happen either during the early phase of headache or before the headache even starts. There's this thought that aura should happen before the headache, but for many people, it's during that dull, achy phase before the throbbing, pounding, disabling pain starts. So this is for people with migraine. This is a typical course. So if you look here below, migrainous cervicalgia, that's neck pain that happens when those sensory inputs are amplified. So migrainous cervicalgia only occurs, as you can see, when the migraine is in this active phase. Does that make sense? Now, the two conditions below, cervicogenic headache and occipital neuralgia, those will probably be exacerbated for the same reasons as migrainous cervicalgia, but those also occur when the person is not having a migraine. So you guys know about the chicken and the egg. So the line below in red is both the chicken and the egg. So that's when this pathology is both triggering migraine, but also will flare during a migraine. While someone with migrainous cervicalgia, really that's neck pain that only occurs with a migraine. So let's talk a little bit about neck pain and migraine. So in this prospective study, 487 subjects, they found that about 70% of these subjects had neck pain associated with their headache to some degree. So neck pain is extremely common in migraine. And I think even these figures don't fully capture. I think if you had a larger sample size, it would probably be a little higher than 70%. So 118 of the, or 184 of these patients noticed the neck pain at the onset of their headache. And like I said, these are joints that really don't have much pathology, that really don't bother you. But then when the migraine kicks in, all those inputs are amplified and it becomes very uncomfortable or even painful. And then 118 of them reported neck pain within 2 hours before the headache. So again, these are people where that sensory hyperexcitability, before the headache has even started, that amplification has already started and they get some neck pain warning them a headache is on the way. All right. And so, when you're thinking about migrainous cervicalgia, is the pain exclusively ictal? Meaning, do I really only have neck pain when I'm having a migraine? Does the neck pain increase in proportion when the migraine intensity picks up? Again, you want to think of migraine or cervicalgia. Between migraine, these patients really have no trouble mobilizing their neck, and they really don't have much neck pain at all. Their exam is normal, just like most people with migraine between episodes. And physical modalities like stretching, massage, and all these things really don't treat this pain because it only happens ictally with a migraine. And again, there's no real pathology that you're treating. It's just that the migraine is amplifying normal signals that are coming from your neck. And rather than imaging studies, empiric treatment is warranted. So we're going to jump into some cases. I always find cases are very good for reinforcing what we talked about. So a 40-year-old woman presents to the office with headache, history of infrequent but severe headaches since the age of 14. They involve the entire head with a throbbing 8 out of 10 intensity and light, sound sensitivity, nausea, vomiting. So what do you think this patient has? Very good, migraine. So about 10 years ago, her headaches started to become more frequent and more severe. She denies any trauma, illness, or any other triggering events, and currently she has daily headaches. Triptans, amitriptyline, and topiramate have helped, but not completely taken the pain away. Physical examination is unremarkable except for a stab of pain in the back of the head on the right side with moving her neck. What other questions would you like to ask? Dr. Sheena. Perfect. Does head turning or contact trigger this pain? Is chronic neck pain or stiffness also an issue for you? Because again, a lot of the time I'm seeing a headache specialist, I should only talk about headache. Wrong. You should mention any other things, especially neck issues, especially jaw issues. Because again, all of these things are compounding each other. What do you do for a living? What are your hobbies? Have you ever seen physical therapy? And is exercise or stretching part of your daily or weekly routines? So what diagnostic, well, what do you think this lady has? She talks about, I turned my neck and I got this quick stab of pain. Anybody? Occipital neuralgia, very good. So the diagnostic test here would be a nerve block. So I did a right occipital nerve block for this lady. 2 months later, she comes back saying the stabbing pain in the back of the head has completely resolved. And her headache frequency, which was daily, has now reduced down to 10 headache days per month. She's able to wean off of topiramate and her headaches remain stable. And when she does take her migraine-specific sumatriptan, it works much, much better now. Because people who have both occipital neuralgia and migraine, they'll take their triptan and they'll notice, oh, the throbbing, pounding component, the light and sound all got better. It did not touch this pain. Because again, this pain is not migraine. Can I take a question? She seems so eager to ask.
We're running behind, so I'd love to have you write it down and we'll follow up during the Q&A.
Okay, thanks.
Am I behind schedule?
You're doing fine.
Okay, thank you. Right, yeah. That's what I get accused of all the time. He speaks too quickly. Yeah, right. Yeah. All right. Case number 2. 65-year-old man presents to the office with headache, history of just to go back to that lady. So this is extremely common. I'll have patients who started having headaches in their 20s, their migraines, throbbing, pounding, and then in my 40s, they shifted to the back of the head. Now they start in the neck. And these patients will often say, I have headaches and I've had pains. And they'll say, doctor, you'll think I'm crazy. I'm like, no, you are speaking my language. I'm glad you're fluent in Matthew. So anyway, 65-year-old, history of infrequent but moderate headaches since the age of 22, involves the entire head with a 4 out of 10 intensity, denies light, sound sensitivity, nausea, vomiting. Anyone want to guess what this is so far? Very good, Dr. Coolidge, tension type headache, excellent. About 5 years ago, the headache started to become much more frequent and severe. He denies any trauma, any illness, or any other triggering events. Currently has daily headaches and neck pain. Patient recently has been tripping and fell twice. Ibuprofen was initially effective, but lost its potency. On physical examination, he has limited range of motion of the neck because of neck pain, and he was unstable walking. What other questions do you want to ask? Dr. Sheena. Exactly, all the same questions. Very good, very good. I shouldn't give him my slide deck to look at beforehand. All right, so what diagnostic would you like to do? Excellent. I see someone pointing at their neck. You want to do an MRI of the neck. And this is what it showed. So as you can see here, that is not normal by any stretch. If a clinician sees that, they drop everything they're doing, they call the patient and they say, dial 911 right now and have the ambulance take you to the nearest emergency department that has neurosurgery for decompression. Because this neck right here, even a sneeze can actually cause a critical compression quadriplegia, because that is what we call a string sign. Yeah. So it's like a string, right? Like it's so narrow. All right. So 2 months follow-up, critical stenosis found, stat imaging. He had a laminectomy, meaning removal of some of the bones back there that are compressing, and then fusion, meaning rods were put into his neck to keep his neck stable. Neck stiffness and pain improved significantly. Headaches now, instead of daily, are 5 days a month with tension type features. Because again, this is someone who has a history of tension type headache, developed this pathology, which was then labeled cervicogenic headache. But in fact, this was the pathology. The pathology was treated. He reverted back to tension type headache. And now he's no longer tripping because, again, that information, he was tripping because your spinal cord is basically a highway, right? So it transfers information from your brain to your muscles. So I want to move my arm, a signal is sent. Likewise, I touch something cold, information is sent from my hand up to my brain. So if you have that kind of compression, your feet will lose their sensation and your footing will be off and you'll trip. So our final case, 25-year-old woman presents to the office with headache, history of infrequent but severe headache since the age of 14, throbbing of the entire head, 8 out of 10, light and sound sensitive, nausea, vomiting. What does this young lady have? Migraine. Very good. So about a year ago, after starting residency, her headache started to become much more frequent, much more severe, denies any trauma, illness, or other triggering events, currently has daily headaches with near daily neck pain. Triptans and NSAIDs have been effective, but the pain always returns. So physical examination was unremarkable. What questions do you want to ask?
Same questions.
Same questions, exactly. Because again, these questions are very useful for deciding what bucket this neck pain falls into. All right. So what diagnostic do you want to do for this patient? I'll give you a hint. So this is somebody with migraine who has neck pain with their migraines. What test do you want to put them through? It's a trick question. So you want to treat them. Because if you think this is migraine or cervicalgia, that neck pain should improve with treatment of the migraine. So in this case, we put her on one of the CGRP monoclonal antibodies, and the headache frequency improved from daily to 3 to 5 days per month. The neck pain was occurring much less frequently and severely because, again, it was ictal neck pain that only happened when she had a migraine. And so she discontinued massage therapy, acupuncture, all these things that were treating neck pathology that didn't exist, right? Because, again, the neck was fine. The neck was sending normal signals that were just being amplified by ongoing migraine. So when you hear neck pain and headache, there's a lot of different treatments. And again, those treatments should be tailored specifically to the type of neck pain that the person has. Medication trials, as Dr. Sheena had said, low doses, moving slowly. A lot of the time, many of our patients are super responders, meaning we put them on a tiny dose of something. And if they happen to have the right subtype, boom, amazing responses. But again, finding that super responder can be challenging. Combination therapies can be very useful. I had mentioned medications, stretching, physical therapy, all very useful. Don't hesitate to ask for a referral. I think the best patients are ones that know about their condition and also advocate for themselves. So if you've been having neck issues, ask for a referral to see physical therapy. If they have TMD, ask for a referral to see an orofacial pain specialist who's a dentist who's had special training in TMD and other related issues. And failure of blocks, as I mentioned, doesn't mean failure of blocks. I can't tell you how many times I've seen patients who have had a nerve block and said, oh, those don't work for me. And I said, trust me, we should probably try it again. And they say, oh, that felt very different and worked better. So I'm happy to take questions, although that'll be later when we have the panel. But Dr. Coolidge does have a question here. What volume do you use for your occipital nerve blocks? Dr. Sheena, volume, the best volume setting for Dr. Matthews, mute. So thank you all for your attention.
Thank you, Dr. Matthew. Okay, we're running a little bit behind, but we can take, how about a 5-minute break so you can stretch, go to the bathroom. If you want to grab a snack or a drink, we will be bringing in lunch shortly. And then when we come back, we'll do our we'll do our next presentation and a Q&A session. So how about 11:35, we'll meet back. Okay. Our next presenter is Dr. Ronald Coolidge, who holds an appointment at Harvard Mass General Hospital, Department of Anesthesia, Critical Care, and Pain Medicine, and has served as a full professor and clinical psychologist at the Department of Diagnostic Sciences Facial Pain Center at Tufts School of Dental Medicine. He has published multiple peer-reviewed papers and 3 books on pain assessment and management, with recent work as a director of the Interprofessional Pain and Headache Rounds, an international education platform reaching clinicians, scientists, and public policy stakeholders. His recent research and grant funding focuses on controlled substance risk mitigation and improving pain care access.
Thanks. I'm delighted to speak with my colleagues here who are actually doing great work. And I'll start off by saying I'm a psychologist by training, sort of a psychologist in remission here. So I'll talk a little bit about more about the comorbidities associated with migraine and headache, as well as comorbid other pain conditions. This is a slide I've been using for a lot of years and published it in a number of circumstances, sort of a model that we looked at in terms of developing a persistent pain conditions, including headache, because I think there's much like that. So I could probably spend the whole time I have on the slide, but instead I'll sort of move on here. If we look at, maybe this is the first time you ever get a headache. It doesn't have to be a headache. Let's say you're doing some yard work and you lift a bag of cement out of the trunk and you hurt your back. It's a pain episode. First time, maybe it's not the first time. Same with the headache. There's a first time you remember, or it happens episodically every year, every month, but there's an event that occurs with an acute episode of pain or headache here, and the pain goes up, and we do things to treat it. We will go in. I'll say we do things, sorry about that. Can you hear me now? I'll shout. We do things to treat it. We lay down, we go take some non-steroidal anti-inflammatory agents. Maybe we go to the emergency room if we break our leg. But anyway, there's some treatments we do here. And most acute pain conditions subside. They get a little bit better. And because we're all normal people who have lives, we go back to a burst of activity. Now, when this acute event happens, regardless of the sort of headache or pain condition, there's a number of things that occur that are very similar. Okay, there's a fight or flight response, heart racing, palpitation, shortness of breath. Even in anticipation of a pain event, there might be some inflammatory response that occurs that protects us. Animals get that before they get attacked in the woods, and it's already kicked in by the time any sort of injury occurs. So this is sort of an acute episodes, and the GI symptoms, visual symptoms, all kinds of things happen with acute episode. I'm not going to talk about that today. I'm going to talk a little bit about what happens when things evolve over a period of time. And this is what my main talk is I use with our fellows, residents, and particularly a lot of the patients who are suffering with pain. We see, okay, so the pain may subside and the headache may subside, but maybe it never goes to zero. Maybe it does go to zero, but then it comes back and it persists. But for a subset of people, there's an exacerbation of symptoms. There's a recurrence of the headache, pain, the event that occurred. And maybe it's after we did something. So let's say we ate something and then we got a violent headache, extremely short time afterwards. Or we did something and the headache came on like a bang afterwards. And the way we exist based upon associations. If A happens, and then B follows it, A must have caused B. So we assume that this event over here, whatever it is, could have been activity, has some impact and maybe caused the pain or the headache. And that's certainly possible. It is also possible that the headache would occur regardless of whatever it was we ate, regardless of that event. And that's the first thing I talk with fellows, residents, and particularly patients about. These associations, particularly with chronic pain conditions, are often not legit because this may have happened here, regardless of that event that occurred beforehand. It also makes us a bit phobic about the event. If we ate something, we're never going to eat that again. If we're out gardening, maybe we hold off on that. And it also makes us phobic about the pain itself. Trigeminal neuralgia, facial pain, severe nerve-related facial pain, is sometimes referred as the suicide disease because it drops you to your knees and people become very phobic about the event. You see this with kidney stones. People, after they've had an episode of kidney stones, they carry a few Percocet around with them for 5 years, just in case they might have another event, because they become phobic not only about the event that occurred in association with it, but the pain itself. So let's spin this out a little bit more. Now it's the worst day of the week. It's the worst week of the month. You're really miserable. Now you're going to go in and see Dr. Smith and Jones. Maybe you're going to go to emergency room by this time. Maybe you have a headache specialist or a pain specialist. And what do those folks do? They do something, which is what you want. So they give you a new prescription medication. Maybe they inject something. They do something here which you request that they do, which is perfectly legitimate. And I always tell my fellows over in a pain clinic, if somebody has back pain, if you're going to do an epidural steroid injection on somebody with back pain, make sure you do it here when the patient is really miserable. Because if they get better, you could claim it has something to do with your epidural steroid injection. But it might not. It might be that the patient got better regardless of that fancy intervention that the patient did. It might be what we call the patient regress to the mean, because a lot of these pain conditions get a little better and they get a little worse, and they get a little better and they get a little worse. And sometimes that complicates our care. I'm not suggesting that there's a placebo role here, but there may be. We do know injections have a greater placebo impact than non-injections. Colored pills work much better than white pills. Capsules work better than pills, and surgery has a better placebo response than almost anything, okay? So I'm not suggesting it's an imaginary phenomena, but we need to take that into consideration because it gets very frustrating. We're not sure what works and what doesn't work in some cases, and patients get frustrated. 100% of people get anxious with initially this process that occurs. I tell patients only dead people don't have anxiety. You have to have anxiety. It's part of the phenomenon, okay? And it protects you. If we track this in for 4 months, 80% of people get some depression symptoms. Doesn't mean they have a major depression, but they get some depression symptoms. And affective symptoms and pain overlap in the brain. So again, a normal response. About 80% get some sleep disruption as well, which we know contributes to headaches. So let's spin this out a little bit further here. And now, by the way, their activity went up over here on the left, and they have pain, and their activity went down. What we're seeing now is pain contingent behavior. In other words, their activity, their life is dependent upon the pain or the headache. So you're not running the show anymore. Your headache is running the show, which is part of the frustration that throws gasoline on a fire, leads to sleep disruption, and so on and so forth. So let's go to the end here. Now, this is the patient that's very desperate. The most I've ever seen was the dose equivalent of about 700 Percocet a day. The most I've ever seen on the tail end here is 43 different surgical interventions for a patient. So we see over a period of time, treatment after treatment after treatment piles on. Now you not only have maybe some successes, but you have what are called iatrogenic problems, problems secondary to the treatments themselves. So you lay down for extended periods of time, and we know for every day you lay down, you lose 2 to 3% of your muscle strength. It takes 2 weeks of activity to fix 1 day of laying down. So you have secondary effects with multiple site pain from the disability associated with what's going on. Non-steroidal anti-inflammatory agents get overused. There's an example my colleague shows in the 1990s where there was 1 year that patients died at a greater rate from NSAIDs than they did from AIDS, okay? So secondary effects of the treatments themselves. Doesn't mean they're bad treatments, but these are iatrogenic effects that occur here. If you wait 2 to 5 years, about 50% of people get a major depression, and there's a risk by death by suicide here. Now let's see, what am I forgetting here now? This is what leads to frustration, but there's some additional factors here. Before this whole situation evolves, There's other things that come into play. Now, see if I get them here. If you have some history of depression before you develop a treatment-resistant headache or pain system, it's a risk factor. It doesn't mean you have headaches because of depression. I'm not saying that, but it is a predictive factor as well. There are other predictive factors here. If you have other physical complaints, you are more likely to develop a new pain or headache complaint. They complicate, they throw gasoline on a fire, they complicate each other. We do know that trauma is a predictor. Again, it doesn't mean if you have any history of trauma or post-traumatic stress disorder, for example, it's a cause of your headache. But there is data to show it tweaks the same area of the brain, and it makes some of your treatments you're going to get for headache or other pain conditions a little bit more treatment resistant, and it requires addressing on its own. So headache comorbidities do not mean that those cause your headaches. They do mean that they should be concurrently treated and recognized as something that will stall the process in terms of treatments. And the big one is catastrophizing. You worry, you worry, you worry, and there's all kinds of data to show that, again, this one very much throws gasoline on a fire, complicates your care, and it decreases the likelihood for treatment outcome. Some people end up here with marked decrease in activity, and they're visiting all kinds of specialists who do all kinds of sometimes crazy treatments. I'm not going to mention their name, but there's a crazy treatment program in, I think it's in Virginia, where people have mortgaged their houses to go down and get these treatments. They're not data-based, but people are desperate. And when people are desperate, they sometimes do different things, and they end up in a situation like this. So I mentioned depression. About 4 or 5 months in, about 80% of people get some depression symptoms, about 50% get a major depression. Sleep disorders are pretty common. We also know that sleep itself, even if you don't have regular headaches, if you disrupt your sleep, you could precipitate headaches as well. So they're all end up getting tied together. And I mentioned suicide risk. So this is the catastrophizing. And we all heard these statements. My headache overwhelms me. If I only get worse, my wife will leave me. And it goes on and on and on and on. I can never work. And the catastrophizing statements throw gasoline on a situation. We get more depressed. And these are a best predictor of treatment-resistant headaches over a period of time. And we often get worried about precipitants. If I do this, I'm going to bring it on. So our world, for a subset of patients, may shrink and shrink and shrink, complicating your care and resulting in comorbidities. Or we go to the physical therapist and we tell the physical therapist, it hurts when I do that. So what's the first thing they say? Don't do that. Yeah, exactly. And often the physicians and therapists contribute to the disability by basically reinforcing pain contingent behaviors. And we could talk a little bit about that, how you could be a good consumer in a bit as well. We monitor. The issue of monitoring is a good idea. We have neurologists here who have you monitor your headaches. Us psychologists do monitoring your headaches to look at precipitants. But it becomes a little tedious. I've had a patient come in with 12 years of monitoring on a daily basis, and she brought in all her diaries. The first thing I told her is stop monitoring your headaches. Okay. The reality is, if you like, it's like if you feel miserable, if you go home, every time you feel miserable, jot it down. I guarantee you a week later, you're going to feel 5 times as miserable. Okay. So monitoring to assess precipitants, good idea. But again, the goal is to not make yourself worse here. I like some history, New England Journal of Medicine, 1860. To take care of one's health is to understand what course of life is to food, clothing, sleep, exercise, and exposure is best, and to follow the habitually without thinking about it. To be watchful of one's health is to keep under constant notice of our sensations, the state of all our organs, the mode of which our functions are performed. He who does this is pretty sure to find that very frequently some things goes not exactly to his mind. He attaches undue importance to it and fancies that it requires a special remedy. It's 1860. So I see this regularly with patients. We go monitoring, and then there needs to be, you need to put brick walls around some of what goes on in terms of your self-assessment, as well as manage your physicians, because they could drive you nuts. Okay. The goal is from a behavioral standpoint, we like to see patients take control of what goes on. So I love posture. Okay. They're specialists. People have spent years working on posture. You have to sit. I notice that 3/4 of people here are sitting crooked. Go for it. Okay. If we actually look at the data, okay, there's probably not a problem with sitting crooked. But again, if you want to have great posture and you get some of the exercise, nice idea, but it's probably not going to fix you. Okay. In general, focusing on posture training to reduce injury. And there's a lot of data on this. The data suggests that it's probably not a very good predictor. So pay attention to it within limits. The Home Depot used to have, for headaches and neck pain, Home Depot used to have a brace that their employees, you remember seeing that? It was a brace that they would wear around. It lasted about 5 months, and they figured it didn't help any bending or anything. They just as many injuries at Home Depot. So all those silly braces ended up disappearing. So you got to be a little bit careful about overdoing the monitoring. Some other examples. This is a $2,300 chair from Herman Miller. And we used to get a lot of requests for chairs, particularly during COVID. You know, your employer should pay $2,300 for a chair, of course, because you're at home and you want to have good posture. I don't know if there's any data for that. This is a $26,000 chair. Okay. I can't imagine how it necessarily is going to fix your headache, but if I get your employer, you have $26,000, buy one of these. Anybody recognize these desks or know of this desk, whose desk that is? This has to do with posture and the importance of posture. That's a pretty lousy postural situation, right? If you're working at that desk, the woman who worked at this desk for about 20 some years wrote about 300 letters to her significant other on that chair, okay, with that desk. She's also written thousands of other poems in addition to her letter. Emily Dickinson, right. That is Emily Dickinson's desk. And you can actually see it at the Harvard Museum. And you can see the replica of the home. And it's really cool, but you got to admit that really sucks in terms of posture, right? So I don't know whether she had headaches or so on and so forth, but she was able to write. And I think we got to make sure we pay attention to the task itself, okay, which in her case was writing, as opposed to the other things that go around our pain care or our headache care. Spouses are important. Spouses could be very, very helpful to you. And there's such a thing as over solicitous. Be careful. Let me get your Percocet. I think we should call the doctor. Spouses can be helpful, but there's data to show that they can make you worse. So you need to train your spouses to not screw up, which is basically means focusing on asking you what you're doing, but not how you feel. It doesn't help you feel any better if they ask you how you feel. So there's some really great even functional imaging data where they stick the person in a scanner and they see where the changes are in the brain. Herta Floor did this work where they put people in a room who had over-solicitous spouses. You know, be careful, let me get you a cup of tea and so on. Floor and some others, I could talk to you about some of these early studies that started in the 80s. They showed that certain parts of the person's brain lit up in the pain area when they just brought the solicitous spouse into the room. Okay, so over-solicitous spouses can be harmful to your health, and you really, really need to focus on managing the folks around them. We could talk more about that. So I can't do this talk on comorbidities without talking a little bit about PTSD. We do know that this is a predictor in terms of developing a treatment-resistant pain or headache syndrome. There's a lot of data on it. It does not in any way, shape, or form suggest that your headache is caused by trauma or PTSD, but it does tweak areas of the brain, and it probably is a risk factor. So if you already have a genetic predisposition to back pain or headache, this will kind of flip it over. And we do know it correlates with a number of areas. People also struggle with this disorder to use various sort of treatments, self-directed treatments. Substance use risk in terms of prescription medication and so on is a problem. But again, the goal is not to necessarily suggest that this is the basis of your headache, but to not treat comorbidities, or to not, as a clinician, as a doctor, to not have the clinician, physician, dentist, whomever, even psychologist, to not ask you about these comorbidities falls below the standard of care. Okay, so they need to ask those questions even though they don't like to, even though it sometimes irritates the patients, but they need to ask those questions because it gives them a hook for treating the comorbidities associated with headache. And it gives you an opportunity to get those cared for, which in and of itself may help better manage the suffering associated with the headaches itself. So behavioral treatments, we could do like a whole course on this. CBT, cognitive behavior therapy, is sort of the gold standard. Talks about arranging perception of a headache and dealing with the negative things you say. There's some great physiologic data on changes. The new version is acceptance and commitment therapy. There's increasing data on headache and ACT treatments. And we just finished a 3-arm study on ACT in pain recently. Don't have time to talk about all of these. You'll read about or hear about pain reprocessing therapy. Actually, a lot of these are very similar. They use some of the same behavioral techniques overall, and you could come to some of our lectures or look at some of our other work we're doing. Relaxation training for pain conditions has been around since the 1930s. Jacobson devised some progressive muscle relaxation strategies before mindfulness and mindfulness-based meditation strategies came really to light. A lot of work in headache was on relaxation training. All biofeedback is, it can measure skin temperature and in part measure muscle tightness, and it's an adjunct to some of these treatments. It doesn't do anything in and of itself. And there's some data to show that may have some impact. Probably actually better data on biofeedback, ironically, on migraine than there is on tension type headache. So it's worth, we could certainly discuss that some more. This is the new rage over the last 10, 12 years. We've done some research on this. You'll hear more about. Operant initially fell out of fashion. Basically, it's a behavioral treatment that focuses on function. How to walk from here to the grocery store despite your symptoms, despite your headaches. And the focus is on taking the attention away from the symptoms of self and putting them on other variables, like how much you're walking. And we're involved in a functional restoration walking program that involves CBT, where we have a patient focus on number of steps they take per day. And it's called the Active Brains Program. Right now, we're accepting people over 60. And it's really cool. The oldest person I have on a Fitbit, by the way, is 96. Okay, I'm going to give you an example of that. So I'm really excited about it because we focus on quality of life stuff, not necessarily just the symptoms, quota-based exercise. And I would say my neurologist and physician colleagues are responsible for writing the medications. It is a behavioral issue about how you use them. 50% of the patients that leave a physician's office don't do what they told them to do. If you add comorbidities to that, it goes down from 50%. And it's not because they're bad people. It's just because there's complex medication regimens and you get frustrated and you're not sure, how the hell to use these medications sometimes. So again, it's a behavioral issue that I think we emphasize in terms of the pharmacotherapy. Now, I badmouth physical therapists and physicians. Let me get to psychologists for a second. Okay, so I had a student who worked for about 6 years in Southeast Asia, in Burma, studying meditation. He was a great expert. And I'm a rehab guy. I get people moving and so on and so forth. And we were a little frustrated because we have a big mindfulness Benson Henry Institute by us. And mindfulness-based treatments are all over the place. I mean, you can't go to Dunkin' Donuts without being introduced to a mindfulness program nowadays. So they're everywhere, okay? And they're really good. They're a resource, no question. But we were a little concerned that all these organizations that treat pain operate in silos. So what we found is, by and large, some of the behavioral treatments, including mindfulness, not only mindfulness, forgot about functional activities. So you teach this patient this wonderful relaxation-based technique, can help with pain, but nobody ever bothered to ask the patient whether they walked to the grocery store or not, or they went back to exercise, or they returned to work. So they miss that. And this is a study we published some years ago on mindfulness-based therapy. Some really good treatment. Over 3,000. Let me back up. Over 3,000, close to 3,000 studies then. There's many more that suggest that these are studies on mindfulness. It's studies of the studies, these are the number of studies who used objective measurements of function. Did the guides in the study bother communicating with their subjects or their patients about functional goals, activities? And we found literally one study that actually bothered to focus on that. So everybody's working in isolation. The physical therapists are over here, the neurologists are over here, the psychologists are looking about trauma, the mindfulness folks are teaching you to sort of feel better, the herbalists are sprinkling things over you, and nobody's talking to one another. So we introduced the Active Brains program through Choir at Mass General Hospital, which has a number of studies that work on a number of pain conditions. Many of you folks who qualify, we talk a little bit about this, but it was our complaint that behavioral medicine people could do better. Exercise. I am not an exercise nut. Okay, I think it's very, very important, but there's tremendous data in terms of exercise, neck pain, pretty good studies, about a half a dozen studies that are pretty decent on headache, and dozens of studies on back pain that suggest that quota-based exercise is the holy grail. Does anybody know what quota-based exercise is? You probably don't know that term.
Is that when you exercise a quota of the time?
That's it. That's it. So with quota, with pain contingent, or I'm going to call adaptive pacing, physical therapists make these cool words, adaptive pacing therapy, you do the activity until it hurts, and then you pull back a little bit. You do it until it hurts, and you pull back a little bit. And we think that's stupid. I'll tell you why, okay? Because when it hurts and you pull back, you have made yourself phobic about the activity, okay? And you conditioned yourself to pull back, okay? With quota-based activity, we make sure the slope is not too high. Goal is to not kill you here, okay? But the slope is a slope regardless of how you feel. Now, this doesn't mean that it's a sunny day tomorrow and you're going to go out doing a long walk at the height of a migraine in the sun. That's not, I'm not talking about that. But I'm talking about in general, okay, focusing on graded base. I'll give you a couple examples of this. And there's a lot of good data to show that works better. And it takes the control in, puts the control in your hand versus putting the control in the symptoms itself. And adaptive pacing therapy added nothing to physical functioning scores. So I badmouth adaptive pacing therapy all the time. We need to look at quota-based therapy with all of these pain conditions in terms of headache. It also is not so bad if it sometimes hurts. Again, from the same rationale. There's a lot of data on myofascial conditions and pain conditions suggest you can do the activity. If you have pain, your all long-term outcome is not going to be bad if there's some discomfort associated with it. So we need to be not phobic about episodes of pain on occasions. Okay. So here's what we do. If we talk about our Active Brains program, pain goes up, pain goes down, pain goes up, pain goes down, could be headache. First of all, as much as possible, I know if we talk about headache, this is not always possible because you want to preemptively and very quickly intervene with treatments, in some cases if they're abortive treatments. But on a general basis, if you're going to do pain relief, headache relief treatments, it's sort of nice to have a fixed schedule. It takes it out of your brain. Please.
The mic for the
Oh,
online.
sorry about it. Nice to have a fixed schedule. It takes that out of your brain. So what we recommend, unassociated with the bumps, fixed schedule, this happens to be walking. Doesn't have to be walking though. 2 minutes of walking, 3 minutes, 4 minutes. Now, I said 2 minutes of walking here, and this is your best day of the week. Why not do 20? Okay, the goal is to stick to the schedule. Now here you're going from 2 to 3 minutes or 20 to 21 minutes. Here's the worst day of the week. Maybe you should rest. Okay, probably not. We know physiologically you could go from 21 to 22 here without, quote, injuring yourself. There's a difference between hurt and harm. And who cares about walking unless you have real goals in there, like walking at a grocery store, bowling, or going out with your family and so on. So this is how we shape some of our Active Brains program using a functional approach. Now here's a guy, I'm gonna give you one example of a headache case. And I hope I have enough time to talk about a couple cases. I'm looking, got some minutes here. Okay, I'm going to talk about two cases, one pain case and one headache case here. This is a guy who had 4 hip surgeries. Nice guy, stubborn. All 4 hip surgeries failed, and he was very frustrated because he has 2 dogs and he wanted to walk his dog every day. So this is before we started all our active brain studies. What we did is we handed him a Fitbit and said, okay, here it is. See what you could do. Now he has 3,000 steps, 8,000, 5,000, 6,000, 4,000. Stubborn guy. On average, he's increasing his activities and he's walking his dog. So he's very happy about that. But there's something wrong with this. What's wrong with it is his behavior is pain contingent. It's based upon how he feels. And he's a stubborn guy and he's pushing through it, but he's still not running the show completely. His pain is running the show. So what we did is we put him on a quota-based program, okay? And on average, the same amount of activity, okay? But now he's running the show. So there's, being a psychologist, I do have some role here, minor in some circumstances, but there is a role in terms of how to structure this. So just, having your neurologist tell you go out and walk more, it's like telling somebody to swim the English Channel by jumping in. See what happens, okay? You drown. So you need some structure to it. We do the same things, by the way, same sort of structured program when we do tapering of medication. All right, this is a lady who I'm told this is somebody in Arlington, and she was in her mid-70s, had chronic headaches and neck pain, probably had occipital neuralgia, no question, and all the other things that we heard about today. But her headaches still persisted over a period of time. And we put her, she didn't want to have anything to do with a Fitbit, but her granddaughter set her up on the phone to track a mapping system like this, which was really cool. So she would add a block with her walking on a Tuesday and a block on Friday. So her map would get bigger and bigger and bigger and bigger, which is really cool. It was rewarding. We also have, I don't have it on the slide, little smiley faces where she talked to the neighbors, which is the holy grail here, okay? So this is her walking program, and you could see it can get bigger. So it doesn't mean we ignored the headaches. Well, we kind of ignored the headaches. We actually focused on her function in this case, which was what we could fix in her case. So I'll have to say the reason I put this slide on is we used to think that aerobic activity, you had to have your heart jumping out of your chest, you had to be extremely aerobic, sweating, all this sort of silliness. Not the case. If you look at most of the studies over the last 15 years, light activity suffices. And I put this on because she's walking like 2 miles in an hour, okay? So this is not intensely aerobic. So light aerobic activity seems like the holy grail. More studies on back pain, but there right now are probably certainly at least a half a dozen studies on headache that are worth discussing in terms of increasing aerobic activity as well. Okay, so a few things. There's a lot of what goes on in terms of headache management and pain management that is a little frightening to me, okay? Historically, we've been struggling to care for people with headache and pain conditions for several hundred years. In some areas, things haven't changed much, okay? And we have a history, a paper we wrote on the business of pain medicine. We started in around 1600. It's a good paper, take a look at it. It'll give you perspective. And unfortunately, there's a lot of things that are not data-based out there. Doesn't mean they're bad, but there's a lot of things that are not data-based. And this is a quote from my friend. I'm an older guy, I may have known him. These kinds of friends also suggest a person suffering from a tedious complaint that he better try X, Y, and Z. Just try this. It does no harm to use this herb or to use this treatment or injection or whatever, are apt to enforce their suggestion by adding, at any rate, it can do no harm. I don't know if you ever heard that. That statement scares me. This may or may not be true as regards to the individual, but it always does very great harm to the community to encourage ignorance, error, deception in a profession which deals with the life and death of our fellow creatures. This is published by Holmes. Read his stuff. It's really cool. Okay. I'm not saying you should be a cynic like me. Okay. I'm on the end here, but you probably should be just a good consumer. And there is a Consumer Reports for medicine. And if you don't know about Cochrane reviews, shame on yourself, okay? Because you should have been taught that. Now, this can really irritate the hell out of your doctors, particularly surgeons don't like Cochrane reviews, because they tell you, at least according to very strict data, what probably works and doesn't work. It doesn't mean you shouldn't have that treatment, but you should at least have the data. And there's a plain language summary in every Cochrane review, and it tells you kind of what works and doesn't work. And it's worth just knowing about, even if you choose to do X, Y, and Z. Okay, so I give those to patients. I'll give you one personal example. I had a cardiac procedure about 20 years ago or so. I had a valve repaired. And I went in to see the surgeon, sort of interviewed him with my wife. And he's a big fancy surgeon at Mass General. And under my arm, I had a stack of Cochrane reviews. And my wife says, "Are you crazy? You're going to go in to see the surgeon who's going to cut you open and ask him questions from the Cochrane reviews?" And I did, okay? And he still did the surgery, and I'm standing here, so we're okay. But I encourage you, it doesn't, and your physician shouldn't be afraid of discussing those things. Okay, this is not headache, but American Academy of Pain Medicine Ethics Charter is a few years old, from Michel Dubois. In the face of severe pain, patients may become desperate and be willing to try anything that a physician suggests. Care must be taken to avoid active or passive, intentional or unintentional, inadvertent coercion. The physician must inform the patient of any recommended therapies that have not been validated by peer review. Again, that this is right. This is right to do. You should know what's good and not. And I think I'm sort of on a rant to do that in many respects. Now, shameless advertisement. I don't get any money from this. This is all nonprofit. I'm fortunate to be co-director of the Interdisciplinary Pain and Headache Rounds. And currently, we reach over 70 countries, most of the states in the US, and we have evidence-based information. About 15% of our patients, our attendees are patients. It is free. It is even free for physicians and neurologists and psychologists, and they get free credit because we have some philanthropy funding. I got guys from Sudan who are logging on to look at these programs every week, and we vet very scrupulously. I have nothing against industry in general, but we don't take industry funding for this for some obvious reasons. And 70% of country, and the coolest data we have now is 46% of our attendees from around the world are in underserved areas. Now, you guys have the embarrassment of riches. We're here in this wonderful room in Newton and so on and so forth. But if you think about it, even within our state, and certainly within the US, there are underserved areas that don't get this information. So we're on a mission to give physicians, psychologists, clinicians, and patients evidence-based information as part of this effort. That's where we're reaching right now. And those that are around, you can email me if you want to go on. Actually, next Wednesday, it's coming Wednesdays on psychological treatments that could go over all the things I didn't get to. I put this boat in here. This is blanking on his name. This is a very famous boat, but I'll think of the name of the person. Anybody recognize it? Why am I blanking on his name? Pardon? No. Who's the guy? Our genetic. Darwin's boat. It's the Beagle by Darwin. It's Darwin's boat. Okay, and called the Beagle. And we put it on as our example because it travels everywhere, gives access to care, evidence-based care, and it sort of gives us, it's part of our mission. Anyway, so that's my shameless advertisement. Yes?
No, so you said that's Darwin. His taste in boats has evolved.
Okay. It happens over time. We regress to the mean and get an average size boat. So I'll defer. I think I've probably gone over a little bit. So thank you for your patience.
Thank you, Dr. Kulich. Okay, we're going to adjust the schedule a little bit. I'm assuming, are you guys getting hungry? I am. All right, how about we do this? we're going to take like 10 minutes. So we have box lunches in the back. They're in 4 piles. The one on the left is gluten-free. They're all labeled. You can grab whichever type of lunch you like, take a little break, visit our sponsors, and at 12, well, let's say at 12:25, so more like 5 minutes, come back to your tables and we'll start the Q&A session. So we can do the Q&A while you're eating, and then we'll do our final presentation. If you have questions that you've written, put them on the table. I'll come around and grab them while you're getting your lunches. So again, just take a quick break, chat with the sponsors, chat with each other, and then I'll reconvene us in about 5 to 7 minutes to start the Q&A session. Thank you.
Thank you very much. I have three.
Um,
Sorry about that.
keep eating, and you'll have some more chance to chat with each other, but I want to keep things moving along. We have a lot of questions, a lot of great questions. So I want to make sure that we can address as many of them as we can. So I'll call the three providers back up to the stage. Dr. Matthew, Johnny on the spot. Okay, and some of these are directed to a specific speaker, and some of them I think we'll just have to see who wants to answer. So the first question is, have there been studies of the correlation between chronic migraine and mental health, such as anxiety and depression? Anyone want to take that?
Yeah, there's a lot of good data on showing that there is an association between depression, anxiety, and chronic migraine. There's also one study that showed that people who have episodic migraines, they're at higher risk for developing chronic migraines if they have depression. And it was, they did some analysis and they showed there's some association, even if you adjust for other risk factors, for example, could be work-related factors and so on. So we say now that depression is an independent risk factor of chronic.
Weird. I lost it.
You said about obesity, thinking about those kinds of subjects, you might want to establish that rapport first before we're talking about it. The other thing I mentioned with a lot of patients is a lot of the anxiety and depression that we see is actually secondary. If you have a chronic disabling pain condition, which really limits your ability to see your friends, go out, interact with the community, and there's kind of a progressive phases to it. First, you start leaving early. Second, you start canceling plans. Third, you don't even make plans anymore because you're so concerned you're going to have an episode during one of these events. So who in that situation wouldn't feel depressed? Who wouldn't feel anxious because of these different symptoms? So for these reasons, a lot of the time when I do talk with patients about it, I often tell them, I think tackling those issues is important, but you might be surprised that a lot of those issues also improve, to Dr. Sheena's point, that if you treat your migraine adequately, a lot of the time those issues also improve. Dr. Coolidge.
I probably would say I feverishly disagree with my colleague, in part because I think from a stigma standpoint, we need to normalize the fact that these comorbidities, including psychiatric comorbidities, are normal responses. And you may only have one shot at a patient as well. So I think that we train our residents. I have a dentist that I work with who is better probably at assessing, you may know Alberto Malacarni, but he's better at doing a PTSD assessment than any psychologist I know. So I'd probably argue a little bit against that. The other thing I'd argue that I think there's increasing medical legal data approaching it from that standpoint, that treating the pain or headache independent, assuming that there's going to be an improvement in their depression, is a risk factor, because the data seems to show that if you, unless you look at them independently, you need to treat the depression. That'll kill you quicker than the headache, okay, in terms of risk factors. So in terms of suicide risk and so on and so forth, waiting till you get efficacy with your headache treatment, I think puts the patient and from what we know from a medical legal standpoint, the provider at great risk. So I think that they could be co-treated. So that's my speech.
Yeah.
Are there preventive treatments for migraine that are safe during pregnancy?
So we generally recommend non-pharmacological approaches during pregnancy if it's possible and feasible. But of course, there are situations where there's more headache and it can actually be harmful to the fetus. So we would suggest have a discussion with the doctor. At times, we may consider using medications such as verapamil or propranolol, like the blood pressure lowering medications, which could be safe. There's emerging data now of using even onabotulinum toxin during pregnancy because of the molecule is too large to cross the placenta barrier. And now we're also having some data showing that maybe the newest CGRP targeted treatments, especially the large molecules, the injectables, may potentially be used during pregnancy, but we're still awaiting more data on those. So there are potential options there, but we also see during pregnancy, the headaches can get better, during especially the second and third trimester. Usually we see some increase during the first trimester and then some decline in the frequency. So that's another thing that we can recommend as a treatment to our patients, but we have these observations. Paul, do you have any other?
Yeah, I had one patient who got pregnant just because her previous pregnancies resulted in an improvement of migraine. And I said, well, now you have 9 months of remission, but that's going to be followed by 18 years of worsening headache. But yeah, no, I agree with Dr. Sheena. And you know, one thing that's very challenging is counseling patients who have never been pregnant before, saying you will always find a reason not to get pregnant, and migraine should not be one of them. Just because, as Dr. Sheena said, most women do experience an improvement of their migraine as the pregnancy proceeds. In terms of acute treatment, there's actually large amounts of registry data supporting the use of sumatriptan. And so I think it's very safe, it's very effective. If a patient of ours is on another triptan other than sumatriptan, we'll often switch them to sumatriptan during pregnancy, even if it's not quite as effective. And keep in mind, sumatriptan does come in 25, 50, and 100. So if they found 100, so yeah, that's my sense. One other thing, and you know, this is just my approach. Many of my patients who are trying to become pregnant, unfortunately, other clinicians will say, oh, you're trying to become pregnant, you need to stop everything, which I don't think is a very good approach, because how long does it take to get pregnant? Days, weeks, months, years? So you're going to leave the person kind of defenseless against their migraine during this entire time of becoming pregnant. So I do draw the kind of crude analogy, and I guess I'll ask the crowd, how many people you know, in this world get pregnant while they've had too much to drink? Right? It's probably a sizable number. And there's no problem with the fetus as long as you stop drinking once you discover that you're pregnant. And you know, I use that analogy because in my mind, that's how migraine is. You know, you stay with your migraine treatments. As soon as you find out you're pregnant, you rapidly wean off of them. The one, you know, exception to this rule would be the monoclonal antibodies, just because those stay in your system for several months after pregnancy. But again, we are getting hopefully more and more data showing that that could be safe. So generally, if we have a younger female patient who is really planning on becoming pregnant in the near future, we tend to avoid those for now, but hopefully more data will come out showing that no, they don't cross the placenta. These monoclonal antibody therapies are safe and effective even during pregnancy.
Yeah, I agree with Paul. There's, I mean, old days, we never even thought about many drugs, you know, prior to pregnancy. There are certain drugs that you really need to be careful, like topiramate and candesartan, because they are proven to have toxicity during pregnancy, and also the valproic acid. But majority of the treatments we have potentially would be, you know, possible to give during pregnancy.
Yeah, so to that point, even if you were on one of those teratogenic agents for 1 or 2 days during your pregnancy, there's no problem as long as you stop it, you know, early on. Yeah. And actually, in some cases like epilepsy, where the risk is worse, some patients actually stay on some of these meds. So.
All right, next question. This person says, I have occipital neuralgia type symptoms, but nerve blocks, which have been performed by a very good and experienced physician, don't help. Instead, trigger point injections really help. Is this common?
So again, techniques are highly variable. Certainly, so trigger point injections generally target tight bundles of muscle, while nerve blocks really target nerves, as the name implies. So it all depends on the volume you're injecting, the location you're injecting, and it also depends on the pathology as well. For some people who have very tight trapezius muscles, may benefit from trigger point injections in those muscles, which you just wouldn't do with occipital nerve blocks. I also tell patients all the time that, I'm glad you're feeling better after the injection, but the way to really maintain that benefit would be to do the stretches that we went over. Also, I will say that when I send patients for physical therapy, I tell them, I'm sending you there. Yes, they may do some modalities with you where you'll feel better, but the most important part of physical therapy is the homework that they give you. And that weeks and months after physical therapy from continuing those routines is oftentimes where you'll see the benefit. It's kind of like seeing a personal trainer 5 times and saying, why haven't I lost 40 pounds yet? Well, it doesn't really work like that. It's when you continue those things that, they really tend to improve. I'm also a big fan of things that are easy to do. So we had talked a little bit about headache journals and diaries. I'll tell you, some of these apps, they want to know what you ate, what you did, who you talked. Like, you spend 20 minutes just filling it out, you bring it to the doctor, and they kind of very quickly glance at it and put it aside. So you really invested all that time to get all that data, which really isn't even really carefully looked at. And a lot of that data is somewhat erroneous and, inconsequential. So, I mean, my headache diaries, they're a piece of paper. You circle your worst intensity, what abortives you took. It's at the end of the day. So before you go to bed, you chart these things retrospectively. So it's not really that taxing. And same thing with neck stretches. I tell patients all the time, you do a couple of stretches. It takes you 10 to 15 seconds, breakfast, lunch, and dinner. So this is a time where there's a lifestyle prescription, not a medication prescription. So instead of 3 times a day, breakfast, lunch, and dinner. Someone had mentioned hydration. Hydration is really important. What I often tell patients is you should hydrate a lot, because what happens when you hydrate a lot? You have to go to the bathroom. So I tell patients, you hydrate, you have to go to the bathroom, you sit back down, you do your stretches, re-engage with your work. As we all know, more and more of our employment involves using a computer and being stationary at a desk. So if you're able to incorporate some stretches with every single routine that you do, and it only takes seconds at a time, it's not particularly taxing. And again, that reinforces better posture and less neck tension.
Yeah, and I agree with everything you said. And also, sometimes we really don't talk about the muscle pain, but it has a huge impact on patients with migraine. And I think the question was asked about that. I feel better after the injections. Even with the occipital neurology, you can sometimes have a secondary epiphenomenon of muscle pain, because we do like people with lower back pain, for example, knowing that the pain comes from the nerves. But at times they also have, in addition to that nerve pain, they have muscle pain. The same can happen with neuralgia in the occipital region. You can have both that and myalgia.
So the way I put it is that your spine is like a pole and your head sits on that pole. And when you hunch and have bad posture, this is what happens over time. So all those structures just get very tight. And then unfortunately, what happens to your shoulders? Your traps will start to alter their tension to compensate for those awkward forces that are going on in your neck. And then patients come to us saying, oh, I have all this tightness and knots in my shoulders, which again is inappropriate compensation for the inappropriate forces in the neck. And then when that goes on for long enough, these very same patients will then start to complain of tightness and clenching in their jaw. And so that unfriendly triad then occurs of TMD, neck and shoulder tightness, and headache, because they all feed off each other. And to Ron's point, you shouldn't treat anything in isolation, but kind of looking at things systematically is really smart, whether it's mental health issues, neck issues, TMD, all these things, all really important to kind of look at the whole patient and treat very holistically, rather than staying in your silo and just isolating your treatment.
Dr. Kulich, when it comes to logging migraine and headache disorders, this is a comment from one of our Zoom participants. I personally feel we must log them to a point due to insurance and if we're on SSDI disability. If we come up for review by chance, we must have a journal or diary of our complex neurological disorders. Thoughts?
Yeah. More than I'd like to think of. I fill out a lot of SSDI forms and so on and so forth. They're not going to, if you have a daily log for many, many months of your headache or neck pain, it's not going to impact your SSDI. In fact, maybe they're going to say you could get a job monitoring on a part-time basis based upon that. So I think if you episodically have logs of your symptoms and you have documentation from your primary care doc, it's not going to be an issue. We don't log forever. My logs are a little different than the neurology logs. For a period of 2 or 3 weeks, if we're doing behavioral treatment of headaches, we do detailed logs throughout the day to take a look at precipitants, ups and downs. But it's a little different model because we're looking at using some of the behavioral strategies to tweak things throughout the day. But then they stop, essentially. They don't continue logging the rest of their lives or ours at that point. So episodically, sure. I could tell you assuredly it doesn't make that difference. I also sit on the Healthcare Services Board for Massachusetts for people with work-related injuries and so on. And it would, you know, the comp carriers, that's the least thing they pay attention to. So stop too much logging.
I will say one quick thing that I do like about logs, though, is when you're instituting a new therapy, particularly a titration. I really like when patients say, when should I go up on, you know, the number of pills, 3 pills, 4 pills? I say, don't ask me. Look at your logs. If your logs look good, hold that dose for a couple of weeks or a few months. I'm thrilled when, you know, the titration, let's say topiramate, it's 25 milligrams working away up to 200 at night. And they said, Dr. Matthew, I got up to 50 milligrams at night and I noticed my headaches were much, much better and I didn't go up any further. I said, perfect. Nobody knows your body as well as you do in terms of effectiveness and side effects. And you did exactly what you were supposed to. So great job.
All right, this question says, I've been taking sumatriptan for 25 years. It's been incredibly helpful. My only concern is, are there long-term side effects?
I mean, so far we don't have any data showing that sumatriptan's long-term could be harmful. We have a lot of epidemiological studies, observational studies showing that even the risk of stroke is not significant unless there are some other risk factors predisposing you to have a stroke. So we can say that triptans are relatively safe. I mean, we only avoid them in patients who have history of uncontrolled hypertension or history of stroke because FDA dictates that. But I know a lot of my colleagues in Europe actually have been prescribing it even to the patients who have had a stroke or cardiac disease too. Again, it will be up to the physician and the patient discussion between the patient and physician about to continue the treatments. But so far, to answer this question, we don't have a really good evidence for saying that long-term use of triptans is harmful. The only thing we recommend is to limit the use for avoiding the rebounding headaches or medication of those headaches. But in terms of like we have patients even in the 70s and 80s are still using triptans without any issues.
All right, this next question, why do you think disability doesn't classify chronic migraines as a disability? I'd love to comment on this one. This is one of my passion projects. So in addition to my work with Miles for Migraine, I've worked with an organization called the Alliance for Headache Disorders Advocacy. We mentioned Headache on the Hill. It's an annual advocacy event in DC. And for several years, I have been working with that organization and communicating with the Social Security Disability, SSA, Social Security Administration, about disability for migraine and headache disease. And I think there are a couple of things at play. Stigma is a big piece of it. Not understanding what migraine really is, thinking it's a headache and that it's something people get over and can feel better. Stigma plays a big part in this. Another potential reason is because it's so common, relatively speaking, There's a lot of people that have migraine. And one of our thoughts in the advocacy space is that there may be some concern that if it was accepted as a disability, it would be incredibly expensive for the administration to pay for disability. That doesn't make it right, and we're strongly advocating against that. But I think stigma is really the biggest reason, and I can say there's a lot of work being done to change this.
I just really want to mention that Headache on the Hill applications for next year are open right now until December sometime, I forget when. So like just Google Headache on the Hill. Massachusetts has a team, New Hampshire has a team, like all the states typically have a team, so.
What is Headache on the Hill?
Can I speak just so the people online can hear? Yeah, so Lisa in the audience for those on Zoom was saying that applications are open right now for Headache on the Hill. If it's something you're interested in, it was a life-changing experience for me when I got involved the first time I went to Headache on the Hill. So do Google that. It's in March of this year. This is an annual advocacy event where patients, providers, caregivers, researchers come together. We do it in person in DC, and we go to speak to members of Congress. We share our personal stories about what migraine is and how it impacts each individual, what your own personal story is. And each year we have a couple of legislative asks. So where we're asking for support on a bill or on funding or report language to help move the needle at a federal level. And when you think about advocacy takes lots of different forms, but this form of advocacy impacts millions of people, the work that we do in DC. So it's not the first step of advocacy, but if it's something you're interested in getting involved in, it's an amazing experience.
Comment on a disability for a second. And again, this doesn't solve the problem that you mentioned, but from Social Security disability standpoint, comorbidities count. Okay, so a lot of people are reluctant to throw in their comorbidities on disability forms, or to have people document their comorbidities, but including psychiatric comorbidities, they very much count in terms of SSDI, and in fact, they are well accepted by SSDI. So I mean, they're high frequency. Don't forget about that from a practical standpoint.
I will say that accommodation forms, although the bane of some people's existence, is something I really like to do for patients. I'm very much eager to fill out whether it's academic or work accommodations to help them really stay engaged and productive, because it's fulfilling. Patients really do like being able to do the things they want to do with some reasonable accommodations. The other thing I will say is if anyone either live or who's tuned in virtually, if you do have forms for your clinician to fill out, please mention that at the beginning of the visit. One of the worst things is you have a half-hour visit and at 28 minutes in, oh, by the way, I have these forms that I'd like you to fill out, which really becomes a time crunch. I personally do not fill out forms by myself. I always do it with the patient, because you want to make sure both of you are in alignment in terms of what is said and what isn't said. There are certain things that the patient may not want you to include on that form. There are things that I normally would have written and they feel may not have fully captured what's going on. So I think it's really important to do that together, whether that's during a virtual visit or face-to-face, but I think that's really critical.
All right, we're going to take a couple more, but we have to be brief in our answers because we're running out of time. Does research on the genetic makeup of migraine brains shed light on promising new strategies in metabolic health or any other areas?
Yeah, sure.
Can you repeat the question? I'm sorry, it's like a long.
Essentially, does the research of migraine point to promising new strategies in metabolic health or any other?
Yeah, it's actually an interesting question, because especially with the new treatments available now for modifying the metabolic health, I mean, you're probably pointing towards the GLP-1 receptor targets. So there is an emerging data showing that actually modifying those receptors may help the headaches. And there are certain conditions that there's a condition called idiopathic intracranial hypertension, where these drugs have been already studied and shown to improve the disease, but there is an emerging data for migraine, so there is potential for these drugs in the future may be offered to our patients. But we need more randomized studies and control studies.
Dr. Ashina, which type of magnesium is best, oxide or glycinate?
So what we need essentially our patients to take is magnesium. Magnesium needs to be bound to oxide or glucinate. So it doesn't really matter which, it's what you tolerate very much, because there are some patients tolerate better oxide or glucinate and vice versa. There's also magnesium citrate available on the market. So because you cannot just take magnesium alone, so you need to bind it or something. So it really doesn't matter to my opinion, although you may have different opinion, Dr. Matthew.
Yeah, I will say citrate tends to make you go a little more. So if you're taking it for constipation and the citrate is too strong, you may want to go with the oxide. Price point can also make a difference. Oxide is more commercially available and generally cheaper. And then finally, the one point I will also say is that a lot of the magnesium stores in your body are intracellular. So you might get a blood test and say, oh, my magnesium is normal. It's not the magnesium in your bloodstream we're looking at, but it's intracellular, which is not really well reflected, why supplemental magnesium is really important. And keep in mind, the magnesium you get in a multivitamin or even some migraine-specific combination pills usually will lack the actual amount of magnesium, which we typically recommend 400 milligrams daily. If you tolerate that and you're still having migraines, we'll then say twice a day. Finally, one more quick point about magnesium. It's one of the few preventatives that can also help get rid of a headache. So that's why in urgent care and in the emergency department, people will often get magnesium in addition to the medications they're getting. So if you tolerate it, I often encourage my patients, if you can tolerate it, take magnesium in the morning, because if you happen to have a headache or one's brewing, it may actually complement your usual acute meds.
All right, this is a question from our online audience. Which treatments work best for vestibular migraine when dizziness and light motion sensitivity, not the pain, are the main symptoms? It's hard to find specialists comfortable with this form of migraine.
So vestibular type of migraine is a subtype of migraine. And so the idea is the vestibular symptoms are due to mechanisms of migraine, or they're not due to the peripheral pathology that is in the ears. So just to start with, diagnosis of vestibular migraine is made by us based on what we see and observe. Now, we have included diagnosis in our classification of migraine disorders, but it's in appendix criteria, which means that we're still working on getting this, this diagnosis better. So we still need some more data. We need studies to prove this diagnosis, because the peripheral dysfunction is so common as well, and people can get vestibular neuritis from just cold, and it can also trigger similar symptoms. Another thing is there is a huge correlation between the migraines and vestibular symptoms, or dizziness, because migraine can make dizziness worse, dizziness can make migraine worse, and so on. So it could be comorbidity, or it could also be part of vestibular migraine. Now, in terms of treatments, so if vestibular symptoms are due to migraine, then logically, you will use the same medications which we use for prevention of any type of migraine, and they should help. Personally, from my own experience, I felt that patients who are on for example, nortriptyline, amitriptyline, or gabapentin, and some of the basically anti-seizure and antidepressant medications do somewhat better than being on other medications. But again, I will still, and most of the time, it's not pure vestibular migraine. It's usually migraine with regular migraine or migraine without aura. So we'll still use the same medications, and we'll observe this, the patients and see if there's any improvement.
From a feature perspective, if you have vertigo from an ear issue, that should not cause light and sound sensitivity. So a lot of the time, patients will have what's called an acephalgic migraine, no headache, but they'll have that vertigo sensation and they'll feel light and sound sensitive. So, I mean, that's kind of a very crude discriminator. Is this coming from the ear, or is this the brain kind of over-processing the inputs that we talked about? The other thing is that if it's migraine-related vertigo, a lot of the time, even when the patient lays completely still, that sense of dizziness will improve significantly, but they still feel like there's some degree of movement. While someone with peripheral vertigo, the ear, when they lay completely still, it'll go away. but then when they start moving in, it reactivates it. So those are kind of two very crude ways of determining, is this migraine related or is this peripheral?
Yes, and according to diagnostic criteria now, which we have, you need to have some sort of headache, right? But we have patients who have presenting just with dizziness, but with some light sensitivity and sound sensitivity, and we define it as a vestibular migraine. But if you really question the patients and get a little bit more information, they'll tell you they may have like a little pressure-like feeling in the head. Yeah, we see that all the time with the patients with migraine with aura, with pure aura, when they say, "Oh, I don't have a headache, I just have auras." But upon questions, they may tell you that they have a little bit of like headachy feeling after having the aura.
So much for short answers.
Yeah. Okay, this will be our last question, and then we're going to transition. A family member of mine was recently diagnosed with autism. We share a lot of the same sensory sensitivities. Has there been any research into the possible connection between autism and migraine?
I know of none, but it's interesting. But my suspicion is, given the base rates in the population, a number of folks with autism also have migraine. So, and as we know, when you have some other medical or psychiatric condition or neurologic condition, sometimes headaches get ignored. So my only understatement would be, let's not forget about the comorbidity that happens to be a migraine.
Yeah, so I think statistics would be what answers this question. So 1 in 5 women have migraine and 1 in 20 men have migraine. So when you have such a high prevalence, you will sometimes see some associations, but there's no causality or strong genetic component. Speaking of genetic components, many patients will say, "Oh, I don't have any family members who have migraine." But then when they go back and ask people, what do they commonly say? "I'm not feeling well. I'm just going to go lay down for a little while." Oh, or it's the change of seasons. "These must be my sinus headaches," when in fact, there's nothing wrong with their sinuses. And in fact, they just don't want to tell people that a headache is taking me out of commission. And then they come back saying, "Yeah, actually, I've had a couple of family members that have migraine. This has been very eye-opening because in fact, it is genetic in the vast majority of cases."
All right, so many great questions. Thank you all for your time answering. We're going to transition to our next speaker now. There was also a question about if you can get copies of the slides. We will send them out, except I don't know if, okay, yeah, we will get them to you. Thank you. All right, our next presenter is Dr. Sepide Haridi. She received her PhD in physics with a research focus in biophysics and medical imaging. She's been an active educator and researcher for over 15 years. Sepide is currently an instructor at Harvard Medical School and the program manager at the Sagaru Center for a Conscious Planet, a multidisciplinary research center based at the Harvard affiliate hospital, Beth Israel Deaconess Medical Center. Inspired by her profound experiences with contemplative practices, her current research is focused on the impact of meditation-based interventions on brain health, cognition, and optimal aging.
Good afternoon, everyone. And thank you so much for the opportunity, and great to be with all of you today here or on Zoom. Okay, so our center, the Sadhguru Center for a Conscious Planet, is a multidisciplinary research center at Beth Israel Deaconess Medical Center, which is one of the Harvard teaching hospitals. We're actually a neighbor to Dr. Ashina's clinic. And we started about 4 years ago. November 2020, we started our center, and our director is Dr. Subramaniam, who's a professor of anesthesiology at Harvard Medical School. And he has this passion to bring evidence to the benefits of mind-body interventions like yoga and meditation so that they can be effectively and safely used and integrated into the medical practice. So in our research, we try to incorporate various modalities from behavioral, psychological to blood markers, neuroimaging, and genetic investigations. And so far, we have seen the impact of yoga and meditation practices in various aspects of well-being, including brain health. blood biomarkers, mental health, employee wellness, work engagement, and also even gene expression. So it's very fascinating, newer area of investigation. We're really excited to work within the Harvard community to, support and create more evidence. So we also have ongoing patient programs, wellness programs for different patient populations, working with the patients, with their families, and with physicians to create programs specifically tailored to their needs so that we can support them through their journey towards better health. Our clinic also provides individual and group wellness programs, not only for clinical population, but also for our colleagues or for the general public to, again, address their specific needs. We also offer educational programs like speaker series. We have conferences and events to bring the research in this area to people and to, researchers and to the general public alike. We also have internship programs, and we're also present on social media. So as you know, there's so much research on the impact of yoga and meditation on well-being. And specifically when it comes to migraine, we know that yoga meditation practices help with reducing the frequency, intensity, and duration of migraine headaches. We also know that it helps with stress management, mental health, and also relaxing the muscles that are usually, we heard a lot about, neck pain and those things. Also helps with emotional regulation and pain processing, which are always, other issues that come when you have chronic pain. They also impact our quality of life, enhancing sleep and daily functioning. So all these different facets and aspects that really enhance your well-being if you're dealing with something with migraine. And talking about mental health, our own research has shown in actually one of the practices that we'll do today, that people with severe or moderate levels of anxiety and depression within 2 weeks of doing an online guided meditation had significantly reduction in their anxiety and depression symptoms, which is really amazing. You do something for 15 minutes a day and have these benefits. Okay, so today we're gonna learn 2 practices. One is more focused on relaxing the neck and shoulder muscles, and the other one is a breath-based meditation. These practices are safe and simple, and they're also very easy to incorporate into your daily routine. You can do them anytime, anywhere. And as someone who's recently diagnosed with migraine, I think these practices have really also supported me in managing my condition. So our mental state, our physical posture, and our breath are very much interconnected. You may have noticed when you are angry, for example, you hold your body in a certain way, your breath is different. When you're happy, you hold your body in a different way, your breath is different. So when you're sad or other emotions, usually this happens automatically and unconsciously. So the science of yoga is to use these 3 components, our body posture, our breath, and our mind, in a conscious way, so that we can create certain physiological and psychological states that would enhance our well-being. So I really like this quote: as there is a science and technology to create external well-being, there are also a whole science and technology to create internal well-being. And yoga and meditation practices in general, mind-body practices, are some of these tools that we can add to our wellness toolkits. Okay, so shall we experiment? Okay, so the first practice we will be doing is to relax the neck and shoulder muscles. If you have any injuries to your upper spine, your neck or shoulder area, and you have any concerns, you can always watch the instructions and consult with your doctor before you do the practices. Otherwise, in general, just do the practices to the extent that you're comfortable, not pushing yourself. It's the first time you're doing the practices. So we will watch the practices on video instructions. The first part of it is to show how to do the practice. No need to do it at that time. You will be prompted when we will all do the practice together. And then also don't worry about remembering the instructions. We'll share resources with you after the program, so you can always refer to the instructions and take it home and add it to your toolkit. Yeah, I think that's it. So if you can please play the first video.
Yoga for success, the neck practices. Both the neurological and the energy systems branch out in a big way between the shoulder blades and above. So keeping the neck region in a good condition is very important. Within 3 to 4 minutes of doing these neck practices, you will distinctly see that you are much more alert and the lethargy in the body will be obliterated. There is a higher level of neuronal regeneration, memory and intellect.
Now we will do a certain set of practices for the neck. This will help you to relax the stiffened muscles in the neck and shoulder region. We will look at the first 3 neck practices now. Please observe. Stand with your feet comfortably apart and parallel to each other. Keep your arms and shoulders loose and relaxed. Make sure your neck is loose like a rope, no stiffness of any sort. Eyes closed. As you exhale, slowly and gently lower your chin to your chest. This is the starting position. Now, as you inhale, gently bring your head up and take it back. As you exhale, bring your head down to your chest. This is 1 cycle. You would do this 3 times. Now we will see the second neck practice. As you inhale, slowly and gently turn your head to the right, to the extreme point. As you exhale, bring it back to the center. Now, as you inhale, slowly and gently turn your head to the left, to the extreme point that you can turn. As you exhale, bring it back to the center. This is 1 cycle. You would do this 3 times. And now we will see the third neck practice. As you exhale, slowly and gently bring your right ear towards your right shoulder, to the extreme point you can go. As you inhale, bring it up. As you exhale, slowly and gently bring your left ear towards your left shoulder, to the extreme point you can go. As you inhale, bring it up. This is 1 cycle. You would do this 3 times. Now we will do 3 cycles of the first 3 neck practices together. Please stand. Stand with your feet comfortably apart and parallel to each other. Keep your arms and shoulders loose and relaxed. Eyes closed. As you exhale, slowly and gently lower your chin to your chest. This is the starting position. Now, as you inhale, gently bring your head up and take it back. As you exhale, bring your head down to your chest. Second cycle. Again, as you inhale, bring your head up and back. As you exhale, bring it down. Third cycle. Ensure your shoulders are relaxed. No stiffness of any sort. Now for the second neck practice. Come to the starting position. Your head should be straight, eyes closed. As you inhale, slowly and gently turn your head to the right. As you exhale, bring it back to the center. Now, as you inhale, slowly and gently turn your head to the left. As you exhale, bring it back to the center. Second cycle, right side. Left side. Third cycle. Do it slowly. You can even hold the stretch for a moment and then come back. Come back to the starting position. Now we will do the third neck practice. Again, your head is straight, eyes closed. As you exhale, slowly and gently bring your right ear towards your right shoulder. As you inhale, bring it up. As you exhale, slowly and gently bring your left ear towards your left shoulder. As you inhale, bring it back up. Second cycle. Third cycle. It is an exhalation as you lower the head. It is an inhalation as you bring it up. When you are finished, please sit comfortably. Now we will learn the fourth and fifth neck practices. Again, feet are comfortably apart and parallel to each other. Eyes closed. As you exhale, lower your chin to your chest. This is the starting position. As you inhale, slowly and gently rotate your head towards your right shoulder. As you inhale, your head goes back. As you exhale, it comes down again. Then switch and rotate in the opposite direction. This is one cycle. You would do this 3 times. And for the fifth and final neck practice, rotate your shoulders forward. As you inhale, go up. As you exhale, come down. Do this 3 times. Now rotate your shoulders backward. As you inhale, go up. As you exhale, come down. Do this 3 times. Now we will do the fourth and fifth neck practices together. Please stand. Check to see your feet are parallel to each other. Eyes closed. As you exhale, lower your chin to your chest. This is the starting position. As you inhale, slowly and gently rotate your head towards your right shoulder. As you inhale, your head goes back. As you exhale, it comes down again. Do a full rotation, then switch and rotate in the opposite direction. We will do 2 more cycles. Second cycle. Rotate towards the right shoulder. Ensure your upper body remains still as you rotate the head. Switch directions and rotate towards your left shoulder. Third cycle. Do it slowly with the breathing. And now we will do the 5th neck practice together. Your head is straight, upper body relaxed, eyes closed. Now rotate your shoulders forward. As you inhale, go up. As you exhale, come down. Do this 3 times. Now rotate your shoulders backward. As you inhale, go up. As you exhale, come down. Do this 3 times. When you are finished, please sit comfortably.
Okay, how do you feel? Were you able to follow the instructions? So I know we know that it's best not to do this practice immediately after lunch, but we didn't have any other choice. But usually at home, if you practice, please allow to be on a light stomach, which means about 2.5 hours after you finish a full meal, or an hour and a half after a snack. So you get better, all the benefits. So the next practice we will do is a guided meditation. And whether you've done any meditation before, or is this your very first time doing a meditation, see if you can just go through it as a fresh experience and see how it works for you. Towards the end of the practice, there you will hear a chant. It's okay if you don't understand the meaning of it. See if you can just be with it and see how you feel. In yoga, sound is used as a tool to create a certain impact on our system. So it's one of the tools that is used in the yoga practices usually. So if you can all turn your chair toward the screen, I think that'll be more conducive for you to see all the instructions and be able to follow. So again, the video starts, the first part of the video will tell you how we do the practice, and then we'll do all of it together when prompted. If you can play the second video, please. So any questions about the practices, or if anybody would like to share their experience of how the practice is?
I'm just curious, is there a time of day you recommend if someone like if I want to start a meditation practice? Not sure like when.
Yes, the answer is anytime for these practices, at least and for many meditations, anytime that is most convenient for you so that you can make sure it happens. I think the most important thing that we're seeing in our research is one of the most important things to make sure the practices have an impact and have the best impact is that you are able to consistently do the practices every day, even if it's a 5-10 minute practice. So whatever time that is convenient for you. In case of these like neck practice, for example, it's best that you don't do it immediately after food, but anytime. A lot of the time people do it early in the morning because usually it sets a condition for the day. And then also usually during the day, you might get so busy with your day that that opportunity may not happen. But other than that, anytime that's convenient for you.
Can we get access to that, what we just saw?
Yes, so we,
The question just for the-
yes. This question is, how do we get access to the resources? So we shared a handout with the organizers and they'll send it to everyone through an email. You have the link to these practices and more resources. So you can always.
A follow-up to that is, can you say a little bit about what was being said in that last little bit, so we know what is being said when we're doing
Yes,
it?
so this is a very famous Sanskrit chant from the yogic tradition. The gist of it, what I understand, is whether through pleasure or discipline, whether in company or in solitude, the one who keeps their focus on the source of creation will find liberation. That's my understanding. I don't know if anybody else knows better translation or yes.
Just a quick follow-up question, because I was thinking, oh, my biggest barrier is that I'm a parent, I have a 6-year-old, but then I'm like, is a 6-year-old old enough to join me? Or is there an age you recommend a child start?
Right. So this practice, yes. So what age can children start doing this practice? That's a great question. The first practice, the neck practice, and there are some other similar practices that we can share the resources with you. They can be done by anyone 7 years and older. Usually for the meditations where you close your eyes, like this Isha Kriya meditation, 12 years and older. They usually don't give them to younger children.
Why?
One aspect of it is it might not be easy for them to understand and follow the instructions. So that's usually like depending on how detailed the practice is and what the impact is, they usually have a
Is there
certain.
meditation you could do with a smaller child?
I think in the mindfulness meditation practices, there are programs and practices for younger children.
Thank you.
Yes, sure.
Does this work better on the pain part of the migraine or the dizziness part of the migraine, or both?
The question is the practices we did today, what part of the migraine they impact. We actually haven't done a research study, particularly on migraine patients. We've done this with people with depression and anxiety. We've done with general population. So I don't have the answer to your question, but there is some, as I mentioned, there's research in general on yoga meditation on migraine. And some of the studies show it impacts the pathways of pain processing and also pain perception. So I think that's a question for the experts. Yeah.
You're an expert.
Any other questions, or anybody would like to share how
I was just wondering about just your center at Beth Israel. Is that something that anyone can access? And
Yes, yeah.
be referred by a physician?
No, that's a great question. The question is about our center, the programs we offer. You can I have some handouts on the handout that will be shared, have all the information on how to contact us. We have, clinics that you can come in and be seen by experts. Unfortunately, so far it's not covered by insurance, but we're really working to see how these, these interventions can also be covered. But anybody can reach out to us and either join a program. Some of our programs are actually online, and anybody from anywhere around the world can join free of charge. And then there are some more tailor-made practices or programs for individuals, depending on what they need. We also have speaker series and other events. So you can always join our newsletter. This is the QR code. And then I will have handouts. It will be in our handout. So it will be lovely for you to connect with us, and we can share with you whatever we find. Yeah, thank you so much. I hope you enjoy it, and I hope these practices become helpful, useful to you.
Thank you so much, and thank you all for experiencing that with us. Hopefully that was relaxing for you. All right, we are coming to the close of our event today. One of the last things we wanted to do is just have some discussion. We're going to do small breakouts. The folks online are going to break out into rooms and go over some questions. But since we're a small group, I'm thinking we could just chat as a group. We're not too big. I'm curious to hear people's feedback. Is there anything you learned today that you didn't know before coming? Yes.
So the biggest piece for me, I think, is isolation and knowing, seeing you all and not being, alone with it, really, among all the other things that are really very helpful and important. And each of us is dealing with different symptoms, different triggers, but my takeaway is more of community. It's all about community. And with community, I think, comes advocacy and busting the stigma, breaking the stigma, and sort of just being out in the world, being